So good morning, everyone, and welcome to our seventh annual conference on men's health, especially around prostate cancer in Black men. Today's event is titled The Unique Prostate Cancer Issues Within the Black Community. So we're excited to have speakers today who are going to touch on the topic, various aspects of the prostate cancer journey, and will touch on the unique issues affecting the Black community. So before we start, as in Canada as usual, so we're going to do a land acknowledgement, and I'm going to read this through for you. So I'd like to begin by acknowledging the Indigenous people of all the lands that we are on today here in Canada. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the lands which we call home. We honor their long history of welcoming many nations to this beautiful territory and uphold and uplift the voice and values of our host nation. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improve our own understanding of local Indigenous peoples and their cultures. Thank you. So my name is Ken Noel, and I'm the president of the Walnut Foundation. For those of you who don't know, the Walnut Foundation is a men's health interest and prostate cancer support group. Our purpose is to work with the Black community, and we started out in the Greater Toronto area, but we've now expanded beyond Canada as well, identifying the needs of Black men and their caregivers in the areas of health and related issues, and to provide a forum for discussion in a comfortable and safe and supported environment. Prostate cancer is one of our main goals, and I'll explain that to you later. So for this particular conference, we've partnered with the African Cancer Support Group based in Calgary, Alberta. And so I'd like to introduce Bayo Oladele, who's going to talk a little bit about the African Cancer Support Group. Bayo, please unmute.
Good morning, everyone. Maybe good afternoon as well. My name is Bayo Oladele, as was said. I'm the president of the Oladele Foundation. African Cancer Support Group functions under the Oladele Foundation. The Oladele Foundation is looks after people who are going through cancer, who are, of course, of African origin, Caribbean, or the Black within Canada. And we do not focus solely on one cancer. We look after all the cancers. So it doesn't matter whether you are prostate or you have breast cancer or you have colon, you can come to us. But today we are focusing on prostate cancer, which is one of our main focus. And I'd like to let you know that we help survivors, patients coping with emotional traumas caused by cancer disease. Our aim is to support survivors, patients, and caregivers, and to share stories, symptoms, and information, and coping strategy that will help anyone going through cancer to recover. It's a safe place to share information, coping skill, and most importantly, a place to give and to get emotional support. When you join us, you get the advantage of being an African going through cancer within the Canadian environment. And so our focus is to make sure that we give culturally appropriate support to anyone and everyone that comes to us. Again, we operate out of Alberta here in Canada. Thank you, and yeah, that's all for now.
Thank you, Bayo. Now, one of the things that we're doing today, that this is really an international conference. We've spread the word really around the United States, Africa, and into the Caribbean. So one of the things that we'd like to know from you, for those people who are joining today, is where are you joining from? And I'm going to set a poll up. Please indicate where you're joining from. We'd really love to know where you're joining from today. So I'm going to launch the poll, and if you can please respond to the poll. So please indicate where you're joining from. Okay. So as you can see, most people are from Ontario. There's some from other Canadian provinces. There's from the United States. And there's some people from Europe as well. There's one person from Europe. So thank you very much for letting us know where you're joining from. And secondly, we'd like to know how you heard about this particular conference. And if you can tell us how you heard about it, we'd really appreciate that. So here's another poll. So tell us how you heard about the conference, and it's a multiple choice. All the ways in which you heard about the conference. Okay. So most people heard about it through email, their social media, newspapers, etc. So that tells us what our impact is and how we get out there. So thank you very much for that. Really appreciate that. Now let's get back to my presentation. So why are we doing this conference? So according to the World Health Organization, the number of deaths per 100,000 persons by race and ethnicity really impacts the Black community worldwide. As you can see, it's double any other race and ethnicity around the world. So this is quite concerning. This is why we have to do this conference. In another publication by the WHO, and this is as close as 2020, the top 10 countries with the highest death rate in the world are countries in West Africa and the Caribbean. As you can see, Zimbabwe, Barbados in the Caribbean has the second highest, Haiti, Zambia, Jamaica, Trinidad and Tobago. So this is the reason why we're doing this conference. Now, within Canada and the United States, there's a lot of immigration to these countries from these countries that are shown here. Hence, a lot of research data found that even within Canada, there's a high rate of Black men being diagnosed with prostate cancer, and also a high rate of men dying of prostate cancer. So this is the reason why we're doing this conference today, is so we can talk about the unique issues faced by the Black community, not only in Canada, but through the Caribbean and into Africa as well. Okay, so today's agenda, and I'm just going to run through this quickly. So we're just doing the welcome and opening. We'll have a keynote address by Dr. Akwatu Kenti, who's talking about closing the Black wellness gap, followed by Dr. Neil Fleshner on the impact of genetic risk and prostate cancer in the Black community. And then we'll hear from Dr. John O'Leaf on masculinity and stress management. This is from our work within the community. We found that masculinity was a huge issue that's preventing men, especially Black men, from getting themselves tested. And then we're going to change things a bit and talk about, so what if you're treated for prostate cancer? You're in treatment. Dr. Nicole Colas-Red actually does some excellent work on exercise in the treatment of prostate cancer. And she's going to talk about the work that she's doing and give a lot of tips around dealing with prostate cancer. And then we're going to hear from Movember. Movember is a huge organization that's been funding a lot of research into worldwide prostate cancer. So we'll hear about the things that they're doing. And then finally, we're going to put together a panel discussion of the presenters and a few of our members to really talk about and delve into the issues affecting the Black community. So that is our agenda for today.
Okay. And good morning. Akwatu Kent is Director of Community Resources at the City of Toronto's Social Development, Finance and Administration Division. He has since November 2020 been Special Advisor to the City of Toronto's COVID-19 Equity Initiative and Chair of the Black Scientist Task Force on Vaccine Equity. He is an affiliate scientist with the Institute for Mental Health Research at the Center for Addiction and Mental Health, and an assistant professor with the Dalla Lana School of Public Health. He has collaborated with indigenous communities in Hidalgo, Mexico, and Peru. Mexico and Lima, Peru, to strengthen mental health in primary health care and adapt Canadian health promotion strategies to their cultural context. He has also taught a wide variety of courses, from international health, human rights, and peace building to global perspectives on the health of women and children. Akwatu is formerly the Assistant Deputy Minister of Ontario's Anti-Racism Directorate, as well as CAMH's Director of Transformative Global Health. He has a PhD in Health Policy and Equity from York University and was appointed as a member of the Council of Canadian Academies expert panel on socioeconomic impacts of science and health misinformation. Dr. Kenty has inspired many local efforts to improve mental health across low-income countries in Latin America and the Caribbean, Sub-Saharan Africa, as well as South Asia, through intensive substance abuse training and management competencies for local health. My friend Akwatu has devoted a lifetime to making life better for marginalized people in all continents. I give you Dr. Akwatu Kenty.
Thank you very much for that wonderful introduction. Hey, this guy sounds like a wonderful guy. And Anthony and I go way back. I mean, we were in university together a few years ago. So it was, I say a few years ago, jokingly, but we've known each other for many decades. And it's, for that reason, as well as many others, it's a privilege for me to be here today. And just sharing my, does everybody see the screen? It's all okay? Thumbs up?
Yeah.
All right. So thank you so much for the opportunity to be here today and to talk about some of the lessons that myself and my colleagues on the Black Scientist Task Force on Vaccine Equity have learned from COVID regarding the vulnerabilities which have made us susceptible to COVID in a way that other communities were not, which led to a death rate from COVID twice the white rate of death, of mortality. It's very similar to prostate cancer, where we have twice the rate of mortality for our white peers. And so you see, it says wellness lessons from the Black syndemic experience. I borrowed that term syndemic from an anthropologist. And what he said was that syndemic is when there's a synergy between the pandemic and the social determinants, so that the pandemic grasped onto vulnerabilities created by poor social determinants of health, but the pandemic also intensifies those very same social determinants, making you even more vulnerable, more likely to get severe illness, and more likely to die. So that's the syndemic, the synergy of determinants and infectious disease that lead to higher rates of mortality and actually amplifies the vulnerability that people of African descent face. Now, I thank you very much for having done the land acknowledgement. I just want to say that, and quoting the words of Justice Murray Sinclair, that we need to build a Canada based on shared future, a future of healing and trust. And it's not happening to the extent that it should, because every day, every week, you see revelations that indicate very clearly colonization is still a tremendous reality across this country. And one of the easiest ways is when people talk about the rule of law and what that means. And the concept of the rule of law, what it means really indicates how outside the rule of law Indigenous people are, and when they experience justice. And a similar thing could be said about people of African descent. Allow me also to do an ancestral acknowledgement. I myself am from Trinidad and Tobago, the descendants of slaves and Indigenous people who have been exterminated from the island of St. Vincent, the Caribs, but also, of course, slave masters, genetics as well. And one of the points that I've been making throughout the past 2 years, and actually for many decades, is that the African people who were brought to the Western Hemisphere from Brazil right up to Canada didn't come empty-handed. They came with skills, resources, knowledge, techniques, technologies. And what's since happened is that as the African was caricatured, even his phenotype or her phenotype became the subject of caricatures, so did the legacies that we brought to the Western Hemisphere, which actually shaped the economic futures of the Western Hemisphere. We brought technologies to America, such as rice cultivation. And I cite that specifically because women brought it. And it's also important to note that when the slaveholders went, or the slave traffickers went to Africa, they were also looking for specific talents, knowledge, and skill sets. They didn't just go looking for everybody. They went looking for specific. And so they deprived Africa of critical resources, which would have led to that continent being a supercontinent in 2022, had the demographic sort of trajectory not been interrupted for 3 centuries. It's very important. And I also like to bring forward the name of one individual, Onesimus, an African, probably from Ghana, because he said he was an Akan speaker. So all probabilities aside, almost certainly from Ghana. And Onesimus was brought to Boston in 1712. And in 1716, between 1716 and 1721, Boston experienced a smallpox epidemic. And the person who owned Onesimus, a minister, noticed that Onesimus, everybody was running around panic. Onesimus was chill, even though, living life as a slave was rough. Still, what's going on with you? Why are you not scared of smallpox? Onesimus told this guy, his name was Cotton Mather, that he didn't worry about smallpox because when he was a child in Africa, the healer went around the village. He took some pus from the one who was infected with smallpox and stuck everybody and scratched everybody around the village. And they got sick a little bit, but then after a while, they never got smallpox. And it's that revelation from this African Onesimus that introduces the science of vaccination, or what was then called variolation, to North America. That's the first North American recorded discussion of variolation, brought by this African from West Africa. And Cotton Mather would partner with another physician and do actually some first a rudimentary type of clinical trials to see if it worked. And it worked. And so the Western Hemisphere owes some of its health traditions and health science to African people, but you will never know that from the text. You would never know that from the popular culture. You would never know that from the way we ourselves perceive science. Throughout this past pandemic, one of the key learnings is that science is for Black communities to sort of build the scientific literacy of our community. We don't have it. We need it, especially because we are at the receiving end of so many racial disparities within science where we are not represented in clinical trials. And that also applies to prostate, but it applies to many other things as well. And you'll see, so I sort of signal myself. I'm going to share with you 5 fundamental lessons that we learned during the pandemic. And the reason I say 9, I chose 9, is because in the Caribbean and Latin America, Brazil especially, when someone dies in certain cultures, they have something called 9 nights. Jamaica to Trinidad to Haiti, Dominican Republic, Brazil. And for 9 nights, the person who has experienced the loss does nothing. They're at home, they're in their home. And people bring food, they bring drink, they bring everything. They bring entertainment. And for 9 nights, you're there, you're receiving people every night, the one who's experienced the loss. And what you do is, what happens is that you go through 9 nights of grieving, celebrating, mourning, but ultimately healing. It's a very healing process that's costless to the society. And I never thought of it as therapy. I always thought of it as something to watch you come into the 9 nights, because you have all these strangers coming. When you have a death in Trinidad, all of a sudden you see like 100 people show up who never know the person who died, but they come for the rum, they come for the food, they come for the entertainment, they come for the laughter. And during COVID, for the first time in recorded history since we've been in the Western Hemisphere, people of African descent were not allowed to grieve properly, even though we were experiencing disparate mortality, higher rates of death. And those death rates were extremely high in South America, extremely high in Central America. But in those places, race-based data is not collected to the extent that it is in the United States. And of course, the experience in the United States and Canada is very clear-cut. So that's why I chose 9, because I believe that we're still in COVID, and following COVID, we really have to think through, how do we understand the grief that we didn't really process in the African way that we have, the lives that we didn't celebrate in the way that we are accustomed to, that allows us to move on, the mourning that we usually do. And in some places, the mourning, I mean, like, it really is theater, drama. And I know many of you from different cultures probably have the same thing, but people walk up to your door and everything looks normal and thing, and as soon as they come through the door, they throw themselves on the ground and they're bawling and they're crying and they're screaming. And I say, boy, that is real theatrics. Yes, you really love Thomas, so, but it's a healing process. It fosters relief, and not being able to do that, I think, is problematic. And so I think that that our thinkers and our researchers really have to think about measuring where we are with grief, where we are with resolution, because all anecdotal records suggest that our mental health burden increased tremendously during COVID, and the World Health Organization has actually acknowledged and recognized mental health as a huge additional burden on top of the burden that existed prior to COVID that must be addressed in order for the world to move forward. So lesson number 1 is about the huge risk gaps that Black people, Black Canadians of African and Caribbean and European ancestry, because we have a lot of people, Black people who have come here from England and Spain and Portugal or what have you, and what that did for them during COVID. And there's different types of vulnerabilities, but the health vulnerabilities are the chronic conditions that Black people have with respect to diabetes, hypertension, asthma, high blood pressure, which has been going up over the past 2 decades, especially for women. Just to give you an example, diabetes in Canada, you probably know this already, you probably know the statistics. South Asians have the highest rate of diabetes, followed by Blacks. So the Black rate of diabetes, or the prevalence of diabetes at 12.9% is 6.6 times that of the whites, who have the lowest rates. Similarly, with respect to high blood pressure, in Canada, 30% of Blacks have high blood pressure compared to 21% of whites. And this high blood pressure, of course, as you know, makes us susceptible to strokes, just as diabetes does. So, and COVID was attracted to communicable conditions, especially asthma. And you know, we have a lot of people with multiple conditions. We have a lot of people who actually have hypertension, diabetes, asthma, and are at solid risk. Or also, they're not actually dealing with their chronic conditions well. They're not managing their chronic conditions well, which makes them additionally vulnerable. So that was one thing that we saw immediately, which contributed to our higher mortality rates, and for which we actually have to address it systematically to prevent it from leading to our gross death for the next pandemic. There's already mutations of COVID taking place in different parts of the world. Some of them potentially more virulent than the ones that we're dealing with right now, which means that we could actually go back to conditions in wave 1, where we were 9% of the population, but 30% of the severe illness, hospitalization, and death. And of course, this is very relevant for prostate, because when Black men get prostate, or Black people get prostate, they tend to have comorbidities, which makes them at greater risk of full recovery, even though, you know, if you catch it in stage 1, you almost have an 85% chance of full recovery in 5 years. But when you have all these other chronic conditions that you have to manage, it's a huge challenge. So that's lesson number 1. Lesson number 2 is about substance uses. And again, what this lesson number 2 about substance uses also relates to the real need for race-based data to understand how our community is reacting to crisis, and where are the trigger points that we need to really address our prevention and interventions. Because we have huge substance use gaps that's not showing up in data, because we don't have systematic race-based data in health systems that are provincial across the country. People are afraid, or think that we will be afraid of the results if they collect race-based data, which shows the huge disparities, or perhaps no disparities. It'd be great if we had no disparities. One of the areas, just because it's so little known, I could talk about cannabis, alcohol, and tobacco, but I actually want to talk about opioids, because you probably hear a lot about opioid poisoning, opioid deaths taking place across the country. We have a huge problem in Ontario, huge problem in British Columbia, huge problem in the Western provinces. And a lot of Black people think that's a white problem or an Indigenous problem. I have met very few Black people who think opioid poisoning and opioid deaths is a Black problem or racialized problem, when all the data from the US indicates very clearly that the group that's dying the most from opioids for the past 4 years, Black people, they have the highest mortality. And they have been increasing, their death rates from opioids have been increasing about 44% over the past, since 2020, compared to 22% for whites. And if we had race-based data in opioids in Ontario, I think we would find the same thing. I don't know, I have no idea what it might be like in British Columbia or Saskatchewan or Manitoba, but the states that border Ontario, it's very clear the case that Black people between the ages of 15 to 24 have been experiencing the highest surge in death rates from opioid poisoning over the past 4 years. And some of this opioid poisoning and opioid death was a response to the lockdowns. You know, the way people use drugs and didn't go to clinics where they could have safe use or what have you, or use with friends, also led to people using at home by themselves and dying as a result without medical intervention to save their lives. We also have a wealth gap, and people have been studying this and thinking about this like Anthony Henry for the longest while. But that wealth gap actually proved to be so critical during COVID, because Black people disproportionately lost jobs. They were in service industries, frontline professions, and some kept their jobs, but many lost their jobs. Many people who had 2 and 3 jobs lost one of their jobs, because many of our health workers who were precariously employed, especially not the nurses, but the nurses aid, the people who clean the places, who work as PSWs. As PSWs in Ontario, largely Nigerian women and Jamaican women. That's the largest group of women from the Black women involved in PSW work. And suddenly they found they couldn't go from institution to institution, so they experienced a loss of income. And what that loss meant was that people had to use their wealth to cover their expenses, their savings to cover their expenses. And again, we don't have race-based data for everything, as we did for COVID in Ontario, but for our partners in the US, what they found is that 46% of white people were able to use their savings to pay their expenses. Only 30% of Blacks were able to do that. Most Blacks had to borrow from friends to pay their bills during COVID. And as a consequence, many Blacks lost their homes. They were unable to keep up with their mortgages, missed mortgage payments, lost their homes. And as a result, in Toronto, where I'm fairly familiar with the data, although Blacks account for 9% of the population, we are now 30% of the homeless. 30% of the homeless, 1/3. That's a huge surge because of COVID. And it tells you that wealth has to be taken seriously. And I'm of a social democratic leaning. I'm not a wholehearted capitalist, all in the capitalist model of economics, but without wealth to protect us, without wealth to depend on during times of crisis, we are overexposed and more vulnerable than other communities when things like a pandemic happens, and when we actually suffer most from it. The other thing that we learned during the pandemic, which we knew that racism was a social determinant of health. That's been well established through WHO studies, other studies in Europe, etc. What we didn't know was that anti-racism, especially anti-Black racism measures, worked and would work to mitigate the risk that Black people experience in health settings. And I could cite you where some efforts to address negligent communication. That's poor communication, or communication that's poor because of implicit bias, where the introduction of a greater accountability for that led to communication in primary healthcare being improved, and people felt listened to, and people talked more about what their conditions actually were. I can also tell you that one of the biggest learnings also was in the area of commercial algorithms. That when you applied an anti-racist lens to some of those neutral commercial algorithms, such as the ones that assign healthcare in America to people with complex health needs, what you find is that Black people are being subjected to or getting less care than they deserve. So anti-racism makes a difference, especially anti-Black racism. It's not just about anti-racism. It's about understanding how anti-Black racism works, because anti-Black racism has had 3 centuries to take root and develop and grow, so that even if you find a cure for disease like for HIV, Black people still die and get HIV in disproportionate rates, even though they don't need to. But because of the vulnerabilities that are built into the social structures of the Western Hemisphere, this is what it is. One of the lessons also during COVID was about digital health support and accurate health information that could be provided through digital means that we had to because of the lockdown. So we had to develop digital resources, rely on digital resources, digital mental health apps. And for the most part, it was very good. But what we also learned was that people who are low income and racialized, and especially Black people, have many handicaps with respect to the use of technology, and that it's not just a question of developing digital health tools, or even making those tools culturally compatible with the needs of communities, because we found, English was a problem, so we had to actually translate it. We actually translated it into Amharic. We translated it into French, into Swahili, into not some West African languages. I think it was Yoruba. But we actually had to support people to gain some digital skills. And that once we did all those steps and followed through, we increased COVID vaccination uptake, because people felt more comfortable registering, going in, doing it, given the support to sort of reduce fears, both of technology and of the system at large. And of course, we have access gaps, which you all know about. And this is the way I explain the access gap. There was a study done by Statistics Canada in 2020, which found that we have first national mental health study survey. And we, of course, as you would expect, depression, mood and anxiety problems, for greater rates of prevalence. But what was very interesting was that 66% of the people who said they didn't have a mental health problem, they were mentally well. 66% said that if there was a Black mental health professional near them, they would go and see that Black mental health professional. So here they're saying they don't have a mental health problem, but that if a Black mental health professional was available, they would go and see the Black mental health professional. I think that need to have a trusted source of information, a trusted person that you could talk to, because you so distrust the medical system, you so distrust, and that distrust isn't groundless distrust. Because that distrust is based on experience. It's not book distrust, it's experiential distrust. And I know fully well the distrust, because I know I have a dad. My dad has dementia, he's in an institution. But for the past 4 years, I've had to go shepherd him through this emergency room after emergency room. And my dad doesn't look like me. My dad looks like out of West Africa. He's of West African origin, pure African features. And the lack of empathy was shocking. And if I wasn't there to speak up and said, what's going on? We pay taxes. We need, it's our right, not just to have care, but to have quality care. If I wasn't there, he wouldn't have gotten it. And so what happened during COVID, when it's COVID lockdown, you're locked into nobody could go in with you in an emergency room. You are on your own. And this is one of the things, we talked to the community, we said, you don't want to be in an emergency room by yourself. Because when you're in an emergency room, you need your family with you. But during COVID, if you end up in an emergency room, there's nobody there to protect you from racism. Because racism doesn't stop because of COVID. And so we have this access gap, which makes it very important for us to be able to be straight up about what we're experiencing with health professionals that we trust. And that's in COVID, that's in diabetes, that's in various cancers, breast cancer, prostate cancer. We need health professionals in these arenas that are Black. That's just the bottom line. And not having them there, not having them in research, and then one of the critical areas is research, because unlike the COVID vaccines, which has the highest rate of representation of Blacks ever, that's not the case with prostates research. And so how do we do that? How do we build up and scale up Black representation in these areas? That's a challenge. And we've actually started to address it at the University of Toronto, bringing in more postdocs from all over the world, having more medical students that are Black, creating specific space and specific resources to support Black students into medical school, through medical school process. So for the first time, we have more than one. For many years, I taught in public health, 20 years almost. And if I saw one Black student, that was a lot in taking the grad courses that I taught. But for the first time, I have 3 and 4 in my classes, because I teach a class in Black mental health and anti-Black racism in public health. And for the first time, they're there. And that's partly because of the George Floyd moment, but it's also because of the fact that we have people ready, willing, pushing. And when the opportunity arises, they were ready to grasp that opportunity. Of course, I could talk about this all day long, because structural protections are fundamental determinants of post-pandemic community well-being and recovery. And going forward, especially our people who work in conditions where they're exposed to infectious disease, you got to have 10 sick days. 10 sick days is a basic expectation. You can't expect people to take care of themselves if they don't have the sick time. If their kids get sick, they can take care of their kids. And if they get sick, they can stay home and don't go to work and expose themselves to other illnesses that might make them even more sick and make their colleagues sick. What also the data is showing is that Black communities benefited from the universal income supports in a way that they hadn't gotten before. And so one of the things that has become a sort of an advocacy piece for us is basic income, basic universal income, as well as specific cultural interventions in these disease areas where we need specialized approaches, where we need culturally competent approaches to sort of ramp up our statistics. I should also add that there's an emerging literature that indicates that when disparities are eliminated, our recovery rates from prostate surge, and we actually achieve parity with the white population. And that's been the case with a recent study of 300,000 patients where race was found to be irrelevant because the care that everybody received was high quality care. So high quality care mattered. Similarly, with respect to COVID and COVID vaccines, we were able to achieve parity in Toronto in some of the highest needs areas with COVID vaccines, despite everything. So because of the trust-based intervention approach with ambassadors and Black people delivering the information. So we know that we can have parity on these issues if we address the fundamental determinants and if we provide culturally relevant messaging. Equity matters. Equity in healthcare matters. And I'm just going to end very quickly because I know I'm all the time. You know, the silver lining of the cloud during COVID was the fact that we were able to spend more quality time with our children. And that's so important. Unfortunately, many people were not able to do that. Many communities who are strapped with socioeconomic needs, they have to get out there and work. Parents have to work 2 jobs no matter what. No matter if their kids at home, they can't really stay home and homeschool. So a lot of kids didn't fare too well during the pandemic on the school lockdowns. And some data is already showing projected increases in lower rates of graduation, lower life expectancy in the US because of shutdowns. But I actually believe there might be a silver lining, especially for Black boys, because going to school as a Black child is a challenging condition anyway, boys and girls, but it's particularly challenging for males because from daycare, believe it or not, from daycare, by the way, we experience disproportionate suspensions from daycare. And you would say, well, how is that possible? How could you be suspended from daycare and have a racialized rate of suspension from daycare? How's that possible? Well, it was possible and happening until Ontario made it illegal to suspend kids from daycare from elementary school years. I think Black children and Black youth face multiple microaggressions through their lived educational experiences from elementary school as expressed in expulsion and suspension rates. Just to give you an example, you probably have similar rates in other cities. 9% of the population in 2016, 2017, 36% of the suspensions in the Toronto District School Board. That's 4 times the rate. And it's 36%, but that 36%, 80% is male. 80% is male. And being a young Black male in elementary school, grade 1, 2, and 3, especially where your nonverbal skills, your nonverbal, in terms of experiencing microaggressions and being able to articulate to your parents and for yourself what you experience, I believe that's where our biological weathering begins. And the biological weathering is the physiological aging of your body, and which makes you more susceptible to these prostate risks when you're an adult. It's what McEwen and company developed as the concept of allostatic load, including such factors as cortisol level, sympathetic nerve activity, blood pressure reactivity, to represent the cumulative wear and tear on the body systems of experiencing racism from the cradle to the grave. And I don't know if many of you who come from the Caribbean, I know the Caribbean very well. I know Nigeria a little bit, and Tanzania a little bit, and Sudan a little bit, but I know the Caribbean very well. And in the Caribbean, adolescence involve risk-taking, going in other people's backyard, stealing their mango, stealing their fruit. You were dare to do that, and if you didn't do it, people say, oh, what are you? So, but the shift in the 80s and the 90s was to criminalize activities that used to be normal adolescent male activities. And that criminalization was deliberate in North America, but it influenced and engendered similar cultural shifts across the world. And I believe that although we don't have data to back it up, what we have is anecdotes to back it up, that our own biological vulnerability has been induced by extra stress due to systemic racism, and not just racial harassment, which is human rights violation. So remember, we don't get the name calling we used to get, the physical attacks we used to get. That's now almost exceptional. But what you get constantly is the invalidations. You put up your hand, they don't ask you a question. You give an answer, they don't give you support. They don't say, wow, what a great answer that was. So, you don't get that backup, that enthusiastic response to your intelligence and your beauty, which turns many off to the education system and to their own personal growth. And finally, I like to end with laughing, because as you know, humor is something that mitigates some of the risk, the pain, the discomfort of dealing with prostate cancer and any cancer. And our culture, properly understood and harnessed, is a source of coping strengths and healing, especially the humor. If I had more time, I'd talk about some of the evidence that indicates very clearly how humor boosts the immune system and improves the overall health of patients with cancer. But belly laughing is something we understand. And we have in the Caribbean and Central America, liming cultures, the art of doing nothing. And it's particularly relevant for people who are low and middle income, liming culture, liming. And liming isn't just about hanging out. Liming is about telling jokes and laughing. And it's the most cost-effective resilience building in the world, liming. And in those limings are a repository of many African wisdoms and proverbs, and that's also articulated in song. And I want to leave you with two particular proverbs from the Caribbean that I've used in my conversations with communities, because I've been, over the past year and a half, I've been in about 100 town halls across Toronto with various communities. And from Trinidad, we have a saying, laugh and cry does live in the same house. Laugh and cry, you know it, you heard it, maybe some of you. Laugh and cry does live in the same house. That concept, laugh and cry does live in the same house, is akin to a Buddhist concept of the mind is its own place and can make a heaven of hell or a hell of heaven. Shakespeare said the same thing. The mind can make a heaven of hell or a hell of heaven. We say laugh and cry does live in the same house. That means you have a choice. You can choose to laugh at your situation or cry. You could cry. If you start to cry, you'll cry all day long. That's why it's better to laugh. because laughter reduces the pain. Laughter boosts your immune system, and during the COVID, you need to boost your immune system. The other one, which comes from Nigeria, I got it when I was in a place called Enugu, Nigeria, a couple of years ago, and I used it ever since. They say it doesn't matter, these people in Enugu taught me, how nice a coffin looks. That coffin could be made out of gold. It could have silk sheets, the best, the most expensive pillow in the world, lined with all kind of ornaments. A $1 billion coffin, you can have a $1 billion coffin, and no one is incentivized to get to the coffin sooner. No one. And so that is something that we don't run to. It's something we run from. So when you don't get vaccinated, you don't exercise precautionary health care, take precautionary health care measures. That's actually inconsistent with what your culture tells you to do. And you know, we had a few years ago, I actually experienced some songs where people were talking about the prostate test, calypsos, where they were talking about prostate test, and it was all about machismo and having a man put his hand up your bum and all kind of thing. That was what the calypsos were about. But the culture, there are elements within the culture that informs you very well how to deal with health because you don't want to die. Thank you very much.
Thank you, Kwatu. That was really, really good presentation. Thank you very much. The one thing I'd like to point out, you mentioned about not seeing Black researchers, Black medical people, and when you go to the clinics. I just want to point out that the Walnut Foundation has just invested in an endowment at the University of Toronto Faculty of Medicine, which would go towards funding an award for Black medical students entering the Temerity Faculty of Medicine at the University of Toronto. And that has just started this year. We've put a seed of $26,000 down, and every year we're going to add to that, so that we want to see more Black medical professionals in the university as well. So I just wanted to point that out. The Walnut Foundation has started on that as well.
Excellent. Thank you so much.
Thank you very much. I'd really appreciate it. Dr. Neil Fleshner, who's going to talk about the whole genetics issue. And to introduce Dr. Fleshner, I'd like to ask Winston Class to read his bio.
Okay, Dr. Neil Fleshner is a clinical scientist and uro-oncologist within the Division of Urology at the University Health Network. He's the founder and director of the GU Biobank, the recipient of the inaugural Princess Margaret Hospital Foundation Love Chair in Prostate Cancer Prevention, and is the Martin Barkin Chair in Urological Research. Dr. Fleshner enjoys diverse prostate cancer interests that span clinical, translational, and health services research. His clinical research focuses on understanding how micronutrient use and obesity affect prostate cancer pathogenesis, and to evaluate how related metabolic compounds may influence prevention and progression. This is complemented by a translational research program that aligns tumor biology with patient care through the discovery of genetic biomarkers to aid in the diagnosis of prostate cancer and the development of personalized treatment strategies. Ultimately, Dr. Fleshner's vision is to use a comprehensive approach to improve the experiences of patients with prostate cancer. Dr. Fleshner.
As a clinician, I find sometimes I learn the most from my patients who are outliers, who behave in a non-traditional way. And this is a man, unfortunately, he's now passed on. He was a 58-year-old man who came to see me about 5 years ago. And he had a slightly elevated PSA level, 2.3, and usually normal is under around 4, but even in the 50s, maybe even 1.5, but usually 2.5-ish to 4 is your threshold to do a biopsy. But then I started to talk to him about his family history, and he told me his sister was being treated for ovarian cancer. His mother had breast cancer, his father had prostate cancer. So this strong family history really sort of allowed me to lower my threshold and said, you know what, I better make sure this man doesn't have cancer. And I did an MRI on his prostate, it was normal. I biopsied him, normal. So this gentleman, from, you know, despite my elevated sort of risk or sort of threshold, he was clear, and, you know, we were all sort of relaxed. Unfortunately, he literally comes back 6 months later for a typical follow-up, and he's not feeling well. He's got pain in his ribs, and his PSA is now 868. And we scanned him, and he had spread of disease throughout his body. And we eventually do a genetic test that found that he was a carrier of the BRCA1 gene, and that's a known prostate and breast cancer risk gene. And you can see this is his bone scan showing all those spots of cancer eating away at his skeleton. And to me, this was a very interesting phenomenon, because as somebody who's been treating prostate cancer for many years, 98% of the time, even in aggressive cases, it slowly progresses over months and months and years and decades in many cases. And this man went seemingly from no cancer to fully fulminant metastatic cancer in a matter of months. And unfortunately, as I mentioned, he's now moved on. So we're here to talk about prostate cancer. We all know what the prostate is. We're called the Walnut Foundation because it's typically the size of a walnut in younger men. It grows, of course, as we get older. And for some reason, unbeknownst to all of us, this gland has a high propensity for malignant transformation. And many of prostate cancers are slow growing, but a sizable subset of them can spread and cause cancer. So I'm going to talk to you a little bit about genetics, and obviously I want to keep this simple as possible. So I'm going to talk to you about the difference between a germline mutation and a somatic mutation. So a mutation in general is an error in a gene in your body. And there's two ways that you can have an error in a gene in your body. You can have, as you see here on the left side, what's called a germline mutation. That means you were born with it. You were inherited an abnormal gene from your mother or father, and every cell in your body contains that abnormality. And as a result, you can test these from any tissue in the body. So you don't have to actually have the tumor tissue. You can test it from a saliva test or a blood test. And this gets passed on to the offspring. And an example is the BRCA mutation, which is the unfortunate scenario in that man I just spoke about. On the right, you have the somatic mutation. And the somatic mutation is one that the cancer cells themselves within the organ or within the metastatic sites have developed, because developing mutation is one of the hallmarks of cancers. And these are not passed on to the offspring and can change over time, because anytime you treat a man or woman with cancer, you create a Darwinian experiment, right? You expose the cancer to a new environment, and subsets of cells that can live in that environment will survive and thrive and repopulate the next wave of that particular cancer. We talked about this a little bit, about the burden of prostate cancer in Canada. You can see here on the left, prostate cancer is the most common cancer in Canadian men, about 120,000. It accounts for about 1 in 5 male cancers. And even though many prostate cancers have a reputation of not being too deadly, you can see, you can see here that it's the 3rd most common cause of cancer deaths in men. And it really transforms into about a 1 in 6 risk of dying of cancer, of developing prostate cancer, and about 3 to 4% of male obituaries are, if you will, are due to prostate cancer. One of the tricks of prostate cancer, as I showed you, is that it lives in a bad neighborhood of the body, and it's intimately anatomically associated with the bladder, the sexual apparatus, and the rectum. So you can have side effects in treating this cancer, including impact on the sexual apparatus, urination control, and ability to have a bowel movement and control them. So it's not an easy topic to discuss, but an important one, of course. Now, prostate cancer has an increased burden in men of color, and it's now estimated, you can see here that about 1 in 6 to 1 in 7 Black men develop it, but the average age of diagnosis is younger compared to men who are Caucasian, and more importantly, 3 times the incidence of having more aggressive cancers. And as I just showed you earlier, a lot of men get prostate cancer. A lot of men die from it, but that actual fraction is not that high. It's just that there's so many patients that even a small fraction is a large numerator, if you will. So many men die from it, but many have an indolent disease that can be either successfully treated or in some cases even monitored. But it's the aggressive cancers that kill, and Black men have thrice the risk, or 3 times the risk, of having more aggressive disease. So in addition to race, the family history is important, right? And this is something that's so important in terms of, if you have a first-degree relative, that means a father, son, or brother with the disease, you have twice the risk. If that individual had at a younger age, it's 3 times the risk. And if you have 2 first-degree relatives, it's 4-fold the risk. And it's quite interesting here, because as somebody who most of my life has been studying diet and metabolic changes and risk of prostate cancer, when I started off as a prostate cancer researcher, we believed that only 5% of prostate cancer risk was determined by the genetics, and 95% was by lifestyle. And now, as the technology's improved and the knowledge has improved, 58% of the risk is now believed to be on the basis of genetics, and 42% on the basis of lifestyle. So they're both equally important. So we have a scenario here where we have a more prevalent cancer, a more aggressive cancer, and there's a lot of controversy as to why the disease is more aggressive. And this was touched on a little bit on our prior speaker, who was a phenomenally excellent speaker. You know, are they more aggressive because we're finding them later? Are they more aggressive because access to care is a problem? Or are there true biologic differences? And I think there's increasing amounts of data that suggest that the social determinants are important, but there may also be true biologic differences as well. So this is something we're trying to untangle, and part of our research is to sort of understand this. But I think it's fair to say that there are both biologic differences as well as social and cultural differences that lead to this startling degree of statistics. So a crash course on genetics. So our DNA is sort of like a recipe book, right? It has the information in it to make proteins, or in this case, we're using cookies as an example. The gene has the information, and the protein is the product. If somehow the recipe book is unlegible, if there are errors in typing, or there are paragraphs ripped out or pages ripped out, then you could imagine you lose information, and the end product is not as good as if you had the full recipe. So mutations are errors in the gene, and they have to be significant enough errors such that the protein, in this case, the final product, does not work as well. And of course, this is sort of what genetics refers to. So I'm going to start. I mean, we are about something called cancer predisposition genes. We have many, as you probably know, we have 46 genes, 23 pairs in our body, and they control loads and loads of information. This is sort of the playbook of human life and all life on pretty much on planet Earth. And you can see here a series now of genes that have been identified all over the genome, which is the term used to talk about all of the genes collectively. And we map these genes, and this has been all sort of realized in the last sort of 30 years. So what we want to tell you is what's the state of this whole field. And it's become really important. I think that case of this man from Trinidad in my clinic tells us that we're learning that the genes you're born with in many cases can relate to a disease. Testing, which used to be very expensive, is now cheap. It's affordable, in many cases covered by at least in Ontario, our province, and I know elsewhere in Canada. Testing doesn't have jeopardy socially, and I'll talk a little bit about that. I think it's extremely important. And I think one of the biggest points that we want to drive home today is almost all of the work done to date around the science has been in Caucasians. So and because it's around genetics, then we need to really understand how ethnicity plays a role in all of this, because it may be truly different. So we're going to start with the most basic type of mutation, which is a SNP. A SNP is the most, it stands for a single nucleotide polymorphism. It doesn't really matter what it stands for. This is the most basic of an abnormality in that recipe book we talked about. This would be a typo. So if you read a word that said flour, and instead of F-L-O-U-R, it was F-L-U-O-R, sort of to anyone who would look at it, you'd figure out that the word was flour. And so it has no functional, if you will, outcome, but they can be used as markers. You know, if you could scan for all those typographical errors, you could sort of say, well, do they represent anything for the patient? And that's what a SNP is. And SNPs now, there's been over 280 now have been identified in the human genome that put you at risk for prostate cancer. And you can add them together, because you don't only have one, they may be 50 or 40 or 30. And you can add them together and get what's called a polygenic risk score, which is the total amount of these very small mutations. And this has been now, this is a simple blood and saliva test, and now is just about to come out as a clinically available test to predict risk of prostate cancer. We recently had a retreat, actually about 2 weeks ago, and we had one of our speakers there, and she was part of this paper. So this is a hot off the press. In fact, it's not even on the press yet, but this group recently validated a prostate cancer genetic risk score in men of African ancestry. And interestingly, it seems to perform as similar to a Caucasian marker. So we're going to await the final paper, but this, again, is some of the first work done in African communities, and it's starting to look like, in this case, the biology may be concordant, which I think is great news. So I'm going to shift now. Those are the minor genes. Those are the minor typographical errors. Major cancer susceptibility genes are different. This would be, imagine, in that recipe book, your pages have been ripped out over the years because you gave it, you ripped it out and gave it to your neighbor or your cousin. And now if you're trying to read the recipe, it's a big problem. And this is what are called major cancer susceptibility genes. This is the BRCA genes you've heard about, perhaps, like in the patient I mentioned in the introduction. So this was the first paper that I think really hammered in the importance of this in prostate cancer, right? And it looked at men who had metastatic prostate cancer, and similarly, easily just looked at the prevalence or how often these gene abnormalities was found. And you can see here on the right, basically in 12% of cases, you would find one of these genetic anomalies in the genes that patients were born with, the major one being BRCA2, another one called ATM, another called CHEK2, and another called BRCA1, like the patient I described about. Those were most of them. And there's a smattering of others, as you can see. This particular paper is interesting because if you look at localized prostate cancer, it's 1%. So what this tells us is that if you have one of these abnormalities, you transit from a localized tumor to a metastatic tumor with a higher frequency or a higher acceleration, just like we saw in that patient that I opened up the talk with. And the other interesting thing about these genes is if you possess them, not only, it's bad news if you do, but there's a tiny silver lining, is that drugs that would not work if you didn't have the gene will work if you do have the genetic abnormality. And this is an example of a drug called olaparib. it's down here, but it's a PARP inhibitor that's showing that if you have the biomarker, patients do better. And you can see here some pictures of cancer regressing here. These little lymph nodes in the chest here, you can see are made much smaller when you're exposed to this particular treatment. And it also applies to certain chemotherapies as well, which can render the patient more sensitive. And how does this all work? Well, it's interesting. A lot of these genes are abnormalities in DNA repair. So how does that work? Simply, our DNA consistently gets bombarded by our external environment and gets damaged and mutated, but not surprisingly, we have built-in systems to repair it. I imagine like little pavers going around filling potholes all day long. Our genome has that. In these cases, most of these genes are errors in the repair mechanisms, right? So imagine we can't repair the potholes, then you get a multiplication of more DNA damage and more DNA damage that doesn't get repaired, and the mutations go wild. So what happens is many of these genes that are cancer susceptibility genes are gatekeepers to keeping our DNA healthy. So if they themselves are disturbed, then you get more and more mutation and more aggressive tumors. This has all led to a new emphasis on genetic counseling and testing for patients with prostate cancer and at risk for prostate cancer and family members of those at risk. And we think this is extremely important. And this is something we've embraced in a big way in my center in a program that I've initiated called our GRASP program, Genetic Risk Assessment Program. And we're very interested in getting patients and their family members in for testing. And this is just showing the current the National Comprehensive Cancer Network guidelines around prostate cancer, but basically it includes patients who have family or personal history of mutations. You can see here race is one of the key pieces, as well as family history. So one concern I hear from a lot of patients is, what's the implications of having a genetic test done? Can I be denied insurance? Can I be denied the ability to, or my child be denied the ability, say, to adopt a child if they're in that circumstance? I'm happy to say that the federal government in 2017 passed and has now been upheld in appeal, because the insurance companies don't like this that much, the Genetic Non-Discrimination Act. And basically what this says is you cannot be prohibited from any receiving any goods or services in Canada. I can't speak for other jurisdictions, based on the genes you're born with. I think it's a big step forward. And it's interesting, is about a year and a half ago, I increased my insurance, and I had one of these intake phone visits, and twice in that call, the individual said to me, if you've had a genetic test, please I don't need to know about it, and don't tell me the results. So the insurance industry understands this as well. So this means that there is not any jeopardy for having a genetic test from a societal point of view. So what are we doing at our center? So the GRASP clinic, when we started this, testing wasn't as available for free, and we had raised some funds and we were able to get it done for free. I mentioned cost earlier. It used to be 8 years ago that to test for one gene, the BRCA1 gene, used to cost $8,000. You can now test for a panel of 74 genes for about $200. So that just gives you an idea how, almost like computer technology, this has dropped tremendously in price and availability. If a patient of ours has a mutation, we start what we call dropping the dominoes, right? We start inviting relatives in to get tested, brothers, sisters, children, nephews, nieces, because they all have roughly your first degree relatives would have a 50% risk. Your second degree relatives would be 25% risk, and your third degree relatives would be 12.5% risk of having the gene. And many of these genes don't only put you at risk for prostate cancer, right? They put you at risk for male breast cancer, female breast cancer, obviously, if you're female, melanoma of the skin, pancreatic cancer, prostate cancer, and some others, some hematologic cancer. So our clinic doesn't only focus on the prostate, we want to look at all of the risk that these patients may be for diseases that they may be at higher risk for. So we're very interested in men with advanced prostate cancer and men and following men with hereditary syndromes. We've just recently published a paper, and this is a pretty scary statistic because it was never known before that if you possess a BRCA2 gene, your risk of prostate cancer deaths about somewhere between 35 and 60% lifelong. And as a result of that, we've now started even offering upfront prostatectomy for unaffected men, so men without cancer, if they possess that gene. So that's almost akin to a prophylactic mastectomy or ovary removal that you hear about for women. Our center is the first in the world to start doing that. So that leads to our program in conjunction with the Walnut Foundation. What we want to do is use genetics, use genetic risk score as a way to sort of, if you will, as a flag for the Black community to try and get better involvement in understanding their risk, and hopefully use that as a hook for testing and getting men in testing earlier than traditionally. And this is a key piece that was mentioned earlier, is how much we need diversity in medical research. So this is a nice example here on the left. This is the SNP type studies I mentioned earlier. They're called GWAS studies. Doesn't matter what it is, but what you can see here is this is all the number of patients that have been represented in this genetic research. And you can see here the red bar is patients of European ancestry. That's like 90%. This little tiny purple bar is people of African heritage. This is like 1% might even be, frankly, an overestimate in terms of understanding this. So even though the research is getting better and there is more emphasis now on non-white populations, we need to understand this. And I think this slide really shows it. Like, you need a magnifying glass to see how many patients from African descent are represented in these trials. And you can see it here. In this case, I'm going to back up. In this case, a model that has accuracy, meaning it works well in other populations, may not work well in African populations. And this I think nicely illustrates the basis of why we need that research, because we can't develop a test and not use it, particularly genetic testing, and not and not validate it in all populations, and then use it in populations in which they're not validated, can lead to false results, which would obviously be a disaster. So the aims of our project is 4 aims, and I'll go through them quickly. But the first one is actually to look at the genome of men with prostate cancer. So what we've established about 15 years ago, one of the most comprehensive biobanks in the world. So we actually possess in our biobanks tissue, including blood, from men with prostate cancer. And we, within it, do have Afro-Canadian men. And we were lucky in that we got the ability, when we started this biobank, to ask about ethnicity. And that wasn't so common. And there is a big dearth in part in Canada of racialized information, because it was the opposite. It was deemed to be, almost verboten to ask such sensitive questions. So we do have in our biobanks a number of specimens from men who we know for sure are of African descent. And what we want to do is called a whole exome sequencing. So that's a way of pretty much looking at every word in that recipe book, every letter in that recipe book. And we're doing this for all of the patients, not just Black ones, but because of this grant, we're going to prioritize the samples from our Black patients. And because we want to learn the prevalence of germline mutations in Black men. Again, still not really well worked out. And secondly, we may find newer ones, right? There could be genes that are either new, novel, and that only apply to the Black population. But we also want to know what the distribution is within the Black population. It may not be the same as that pie chart I showed earlier. So this to us is very important. We are looking for additional samples. So if anyone in this audience or anybody that you know has had prostate cancer, it has to be more of the aggressive form. We would be happy to see you in the clinic and take your blood and use this for our research. Very important. Our second aim, which is also very interesting, and this is going to be one of the most controversial things we want to do, is we know that because we've been collecting samples for so long, many of our patients have died. So we're sitting on their blood sample, and we have the permission from them prior to their death to test their blood sample. So what we want to do now is determine in our biobanks among patients who have this, so we test their blood, we find they have an abnormality. We want to try and contact their next of kin and say, oh, by the way, do you remember grandpa or your husband or your brother or your father, heaven forbid, your son? And we think there's a problem in your family and we'd like to bring you in to get tested. And it brings in a lot of ethical issues because so we're working out now really the feasibility of doing this. How do you return results to patients who have now been deceased through their families and family doctors? So we're actually trying to, this is what's called a feasibility study because we don't know how effective it's going to be because it's a bit controversial, but I love doing controversial research. But, we're really trying to see, can we use stored samples as a way to try and save a life or two or five or more among people walking around that they don't know that they have this huge risk. So that's what we're trying to do. The third is really just trying to raise awareness. We showed you the statistics around prostate cancer in the Black community. We're not sure that even the doctor community and the nursing community understand this, never mind the walking patients or prospective patients. So we want to raise the awareness of hereditary prostate cancer and prostate cancer in the Black community. So we're going to be developing a slide deck, an education plan for physicians, for primary care doctors, specifically on this, and they will be able to get credits, as their continuing education. And we're going to really develop this in conjunction with the College of Family Physicians of Canada, as well as the Canadian Neurologic Association. So we're going to really try and start with physicians in underserved areas, but really across the board. We just think that this whole association of race, genetics, and prostate cancer, we need to raise the bar among the physician community. And even more importantly, we need to disseminate these findings to the community at large. And this will be with the Walnut Foundation and community partners. And we're not sure how this one is going to actually look right now, but we have a board and we're going to work forward with this and try and leverage also funds perhaps from industry to develop a campaign, likely social media. We want to improve early detection treatment. We want to invite people in to get genetic risk scores so that we can, again, use that as a way to not scare. I always say we want to scare patients enough not to make them anxious and ruin their quality of life, but have them just a little bit enough worried that they actually follow through with annual testing, for example. So we're prepared to not only social media, but get out there ourselves and talk to people wherever they need to be to try and raise awareness. And so we have a little survey there if you want to answer a questionnaire that we're developing. That would be helpful as well. So this is sort of how we're thinking about this problem and trying to move it forward. We recognize this aim 4 is a tall task. This is going to be the hardest one to measure, the impact. But nonetheless, we like this idea of going from the bench to the base to the barbershop, if you will, as a way to improve our understanding of the science, but also trying a social approach to improve outcomes. So I'll just conclude. Again, thank you. I'll try and give us 15 minutes back. The genes you are born with impact your health outcomes, and as technology improves, you know, we're going to all understand this, and this will become more prevalent in our lives. I'm sure in 10 years we will all buy a whole genome for $50, and it will become part of our health record, and that's going to give you a slew of diseases and conditions that you're at high risk for. Our GRASP program was set up really to streamline care for patients with genetic anomalies, but also to be a living laboratory as a place for us to learn. And we're very committed to our new health equity research program, which we're going to start with the Black community. It's not only the Black community, there's a dearth of understanding in Asian communities, South Asian communities, for example. We're doing some work in India, because we want to not only promote novel scientific discovery, but we also want to improve care. And you know, an interesting comment was made by the last speaker, which said, you know, there's some evidence that maybe it isn't a biologic difference, that in an equal access healthcare system, the outcomes are the same. I think that's, even if that is true, are we comparing apples to apples? For example, if a higher proportion of Black people are coming in with incurable disease than white people, then more upstream we've got to focus. So even though the outcome from the metastatic disease may be the same, if the proportion of people with metastatic disease is higher, then we've got more work to do upstream. And that's the kind of work we're going to try and do over the next few years with this project. I know this is we're probably speaking to the converted here, but nonetheless, if you know folks who've had advanced prostate cancer and are still alive, we would love some of their DNA. If you know people like that and they want to come in and get a test, or even if a relative of someone who has passed wants to come in and get a test, we would be happy to facilitate that through our clinic. That's what we're here for. And you've got Jess Coburn's email there. You can contact her, and we're happy to look after you. So I will stop at this point, and happy to take questions, although I think we're going to be doing that later, but I'm happy to do that now.
There are a number of questions in here. I'm just going to go through them quickly for you.
Okay. Yeah.
Is there a bias against active surveillance in the Black community?
I don't believe so. I think it's a good question. Just some background. Active surveillance is a program by which, I'm going to stop my share, by which men of who possess a certain number of traits, typically low volume, low grade disease, are just make sure, yeah, low volume, low grade disease are placed in a program. I think because Black men are getting diagnosed later, they're not as eligible for surveillance based on their disease. I have many Black men in my community who are eligible for, in my practice, who are on surveillance. So I don't think there is. I mean, something that could be studied. I think if you look at rates of active surveillance alone in both communities, I'm not sure it addresses the question right. I think it gets to the same question, dilemma we talked about earlier, is what you'd have to segue is what proportion of those eligible for surveillance are being offered surveillance. And my guess it would be the same, but I could be wrong.
Yeah, there's another one. Are both germline and somatic genetic testing covered by our healthcare plans?
In certain cases, in Ontario, yes. In other, I can't vouch for other. It's a little spotty in other provinces in the States. I just don't know. So it depends. But yes, if you fulfill the criteria for testing, so if you have a family history, if you have those criteria I showed, if you have a family member, if you have prostate cancer at a young age, regardless, we'll get you one for free. If you want to come down, even if you're not eligible, we will. That's one of the missions of our clinic. And I have, I think, a few thousand tests for free that we could always offer. So
how do you balance the biological and social cultural factors that influence the risk of prostate cancer? Is there a risk for the medical research community to center gene risk over addressing the social determinants of health? It's a long one.
Great question. It's a very good, look, I think we have to push on both fronts. It's as simple as that. I mean, we need to understand the biologic differences if they do exist. And then we need to understand the social cultural. Well, I'm not a social cultural scientist, so that wouldn't be my forte. But I think we have to push on both fronts, because look, the best science in the world is useless if you can't get patients access to them, treatments, whatever they are. So we, you know, as Canadians in particular, we're very much believers in healthcare as a right. I strongly believe in that as a human right. So, you know, but I think we should also push on the science, because if there are differences, we could use those differences again as a way to inform and get patients again, or prospective patients, anxious enough to get tested, not to ruin their lives.
How do you avoid medical stereotyping?
Oh my goodness. Oh. Wow, way above my pay grade. I think the first talk addressed some of it. The only way is education. I mean, it's as simple as that. The only way we're gonna make planet Earth a more habitable and hospitable place is for all of us to do that. I mean, I think medical stereotyping is societal stereotyping. You know, and it's, you know, it never ceases to amaze me how, no matter how educated, sophisticated some people are, they still harbor a lot of that old stuff, right? So we have work to do as a collectively, as a society.
So the next one is great to hear about the GRASP clinic at PM. Is there provincial health coverage for genetic testing and counseling for men at risk of prostate cancer, or movement towards that?
We will look after that if you want to come down. If you're outside Toronto, like if you're in North Bay, and there are provincial guidelines for testing. It may not, but there's also long queues. So if you don't fulfill the provincial testing guidelines, we'll offer it for you for free, as long as if you just slightly fall outside of them. I mean, if there's truly no need for it, then you don't have to have it. But we will, the short answer is I'd say 80% of time the test is now covered, and that's brand new. That's all a year old. So.
Yeah. You may have addressed this next one. How does one get, as a Black person, get involved in genetic research, those with or without prostate cancer?
Oh, well, if there's a history of prostate cancer, I assume there is, because you're on this call, we will look after you. Contact Jess Coburn, we'll look after it for you.
Yeah. The other one is, does UHN share its research info and collaborate with the Odette Center at Sunnybrook?
Yes, absolutely. And in fact, I also work at Sunnybrook, and we work collectively with Danny Vesperini, who also has a clinic program working there. So yes, we do.
As part of your genetic research, do you get information from other hospitals such as St. Joseph's?
No. So, I mean, unless you fulfill the provincial criteria, well, I'll say this, it's also new. I don't know that I can answer. Well, I'm assuming once we have thousands of men tested in the province, and it will end up on some kind of electronic medical record, the answer will be yes. Right now, the answer would be no. So if St. Joseph's were to do a test on you, we would have to just request the results and they would be sent. But, or if they haven't done it, we could always request the tissue or just repeat it from your blood test. But if it's a somatic mutation, we often do this all the time. We get tissue sent to us from another hospital and we analyze it.
This last one, is there a place for CRISP therapy? I'm not too sure what it is. CRISPR therapy in prostate cancer at present.
So I think it's referring to CRISPR, which is gene editing, right? The idea of fixing the typographical errors in the recipe book. Still very futuristic. There is some CRISPR work going on in cancer. It's mostly starting with simpler genetic diseases. Cancer, CRISPR technology is a long ways away, and certainly not so even further away in prostate cancer.
Okay. So those are all the questions so far, and maybe, you know, when you get back later on,
Sure.
you know, there may be more questions for you.
Wonderful.
So I really want to thank you. It was an excellent presentation. We got a lot of comments about that. It was an excellent presentation, very informative, and really want to thank you for this. It's been
Thanks, pleasure. And again, I'm really pleased to be here today. So I will sign in later.
Thank you very much. We'll do one final presentation before the break. But I just like to let you know that I want to welcome more FM 91.7 in Jamaica who are streaming this conference live on their radio program. So I'd like to welcome people from Jamaica signing in and listening to this. I really appreciate Patrick Williams and the people at Moore for streaming this live to Jamaica. Thank you. So the next speaker is going to be Dr. John Olive. And I'm going to make John a co-host. So I'd like to have Bayo Oladele introduce Dr. John Olive. Go ahead, Bayo.
Dr. John Olive is a professor and a Tier 1 Canada Research Chair in Men's Health Promotion at the School of Nursing, University of British Columbia, Canada, with a joint fractional appointment at the Department of Nursing, University of Melbourne, Australia. As founder and lead investigator of UBC's Men's Health Research Program, his work focuses on masculinity as it influences men's health behaviors and illness management, and its impact on partners, families, and overall life quality. Findings drawn from his research offer guidance to clinicians and researchers in psychosocial prostate cancer care, smoking cessation, and male suicide prevention. John has also leveraged descriptive research findings, and needs analysis to design and formally evaluate tailored e-health and community-based interventions for men and their family. Please welcome Dr. John Olive.
Morning from the West Coast here in Vancouver. It's delightful to be able to share a little bit of information and maybe have a bit of a conversation about masculinities and how we think about masculinities and stress management today. So I'm going to just move straight through. Some of the things, just to say, some of the things I talk about today, they can kind of trigger some experiences that might have been pretty challenging for you all. I encourage you to reach out to me, to engage in the chat, to sort of work in with some of these. So mental health is not always easy to talk about. I try to make it pretty straightforward in terms of talking about how we might think about it as men and how gender might be involved. Just to say, I've got I usually have deliverables within a presentation, so I know I've got 45 minutes and probably a little less, so I'll try to get you to your break on time. But just to say, there's kind of 18 things I want to do. I won't belabor them here, but I'll just launch in and we'll try to piece them together a little bit. The year is 1969, and I'm just tilting my 6th year. I'm like about 6 years old, and I'm in the front row of a town hall in a mining town that's aptly named Broken Hill, and it's in the state of New South Wales in Australia. And it's an important day because I am going to graduate. grade 1. And the deal is that you walk up the 3 stairs, you turn to your left, you shake Mr. Jenkins' hand when he calls your name, he hands you the certificate and you gather on the left-hand side of the stage. And so I've had some challenges at this point around alphabet and arithmetic, and I'm not really tracking super well, but I'm so delighted to graduate grade 1. So Mr. Jenkins starts calling the kids' names, Karen Afford, John Bautez, and I'm kind of edging towards the end of my seat because I know I'm mid alphabet. And then it's Michael Noonan, and then it jumps to Olivia Otto, and then he calls a slew of P names, R, S, T names, until Mr. Jenkins at the end says, and the final person in the graduating class of 1969 in Broken Hill is Anne White. I look to my mum who's with me and I say, what's going on? Like, I didn't get called. And she doesn't answer me. And then my teacher, Miss Trudy, at the end of all the kids graduating, like grades 1 through 6, she comes to me and she says, in a kind of weird civilian-like voice that I hadn't heard in the classroom, she says to me, hey, great to have you in the class, John. Have a great Christmas. And I couldn't lift my eyes to look at her because it would have been the final indignity of knowing that my grade 1 class just graduated without me. And it is affirmation that I kind of failed grade 1 in a mining town. So I'm like, I just literally couldn't deal with it. The drive home in the car with mum, I say, took a very long time for a very short distance. And every time I tried to raise the issue about what happened, how come I didn't graduate, it got shut down. About 3 weeks later, my dad came home from traveling for work and he says, we're moving. We're moving from Broken Hill to a place called Adelaide. And I'm like, okay. And I thought as a kid, I might have been in the witness protection program at that point. I thought, you know, it might be the kids who kind of fail grade 1, their parents are so ashamed that they move them to another part of the country. So we moved from New South Wales, where Broken Hill was, to South Australia, where Adelaide was. I'm the kid who's forever in the back of the classroom, who's forever struggling. And in something that I still can't explain, they put me into grade 3. Even though I failed grade 1 in Broken Hill, I was in grade 3 in South Australia, and I was battling, big time battling. I reflect on this a lot, and it helps me to think about how we protect our boys from vulnerabilities, how we kind of don't acknowledge, you know, the things that might have gone better, that we tend to want to keep them out of harm's way. And it's a great reminder. And I think we do it because we're trying to help them avoid vulnerability and we're trying to help them build resilience. And I'd say that little boy's still here for a lot of us men as we grow older. That kind of, that resistance, that put the Band-Aid on, that cover it up, the vulnerabilities are incredibly hard to talk about. I think in the space of mental health, we get these examples of really successful guys who talk about their mental health challenges. And we kind of like go, that's great. We're kind of destigmatizing it. But for many of us, we kind of keep it inside and we kind of push back on the vulnerabilities. And I would argue that prostate cancer, it disrupts us. It is a vulnerability of all sorts around relationships, around our mortality, around our morbidities, around how life is going to be. And they're hard things to talk about. They're really difficult. And part of what I'll share today is that if we don't talk about them, if we don't find a way of adjusting, of working our way through, they can manifest as mental health challenges. So my point of all of this vulnerability talk is to say that we need to be able to destigmatize the issues around mental health and specifically around men's mental health. I think COVID, if it had a silver lining, it was probably that when I talk to people now about anxiety and depression, they know what I'm talking about. I don't think any of us were untouched. I think COVID just created a great deal of uncertainty. It slowed things down to a point where you thought about the past. You had to and some of us kind of got caught in the rumination of that. So very challenging times. So just to say, the talk is really important. It is not easy, but I've got a few ideas. We do a lot of work with men around depression, depressive symptoms and anxiety, and we ask them to take photographs of their experience of mental health and mental health challenges. And here's a little theory about what happens in terms of many men's lives when they have what I'd say is an injury. So it's kind of interesting. This picture was taken by a 20-some-year-old man, but I think it still resonates, you know, as we grow older. It's a picture of an apartment block that is condemned, that is going to be torn down. And he's referencing his mum and dad who divorce, and neither one of them expresses an interest in having him live with them. And then he has a relationship that seems to be tracking okay, but his girlfriend dumped him. And he just says, eventually, you might just end up being abandoned. You're going to be abandoned. The point of this slide and the point of the picture and the point of his narrative is very much around this idea that we carry injury. And things that we sort of think we should get over, we don't always get over. And I think as we grow older as men, a lot of times these injuries accumulate. Like they're a cumulative effect. The weight of them tends to bear down on us. Because if we don't fully deal with the injuries, they kind of have a way of pushing us. So the other thing that happens after the injuries or with the injuries is we tend to look inside. So this interiority. So we look inside for resources at a time when we're quite fatigued and depleted by the injury, and we're trying to find our way through a lot of these injuries. We're trying to be self-sufficient. We don't want to burden anyone. We don't want to ask for help. We kind of just want to fix it. It needs to be better. We kind of know that. We might deny it. We might even blunt it. So a lot of times we'll do alcohol and or drugs to sort of kind of blunt some of the things we're feeling. So this is a lovely analogy from a 54-year-old man who says, you know, you can get locked down, locked into your thoughts. And then he kind of dovetails into a little bit of quote at the end there where he says, you know, if you don't know the combination, then you don't know how to get out of the depression and the suicide. But if you know the combination, you're able to unlock. And it's just a beautiful analogy about how we look inward to try and deal with things that are troubling us, i.e. the diagnosis of a prostate cancer, a treatment, the aftermath of a treatment, the adjustment in the relationship, all of those things. So we know that when guys push down their emotions and they suck it up and they don't cry, they lose touch with their feelings. Impulsivity is one thing that kind of can happen, but also the recognition of what you're feeling and the management of the distress are completely impeded because you're denying what's going on. So it can be really, really tough. And the third thing, the third eye is around isolation. So oftentimes when guys are going through injury, this interiority is kind of failing, but they're still in the space. There'll be this isolation. So this guy, 60-year-old guy driving home from work, he works in an open office plan. So there's like 100 people in this office space. So he's not alone, but he's profoundly detached from everybody who's there. He's quite alone. And he says, this is his drive home. And he says, it feels like everyone's separated from the world and you're just all by yourself. It's a feeling that's so unbearable, you just want to get rid of that feeling forever. Just a really poignant example of when problems don't get addressed, how they can get driven inward, and we just might not have the resources to deal with it. And then we tend to conceal and we tend to isolate. And isolation is one of the biggest risk factors for suicide in men. So again, we want to try to get upstream of this. The full paper is available freely online. It's called Injury, Interiority and Isolation in Men's Suicide. It's Suicidality. It's well worth a look. It gives us a bit of an insight. So I wanted to invite you into the conversation because I firmly believe that support groups do such great work. I need your help with a scenario, to be honest, and maybe we can facilitate some comments into the chat and we can hold them till the end, or there might be an opportunity here to kind of speak up to kind of help me work this out. So Jimmy leaves early for work these days, and he seems to be staying late, even though he doesn't need the overtime. He's also withdrawing from friends and family. He no longer sleeps in the same bed as his wife. He's been changed by the prostatectomy for his prostate cancer. His thoughts are scattered, and he misses sex way more than he ever imagined. So my question to you all is, you're kind of sensing Jimmy's pain here, but I just wonder what we would say and what we would do. What would be the ways that we would connect? How would we get the conversation? How would we engage him in the opportunity to speak up?
You want him to put that in the chat, John?
Yeah, Ken, happy to put it in the chat, but if there's someone who'd like to respond, it might be nice if we've got a minute or two to get a sense. Because I'm sure there's lots of wisdom out there about how we might, how we might engage Jimmy around this.
If someone wants to respond verbally, they can raise their hands and I'll open the line for them.
Okay. Shall I just keep going in the interim, or shall we wait a little? Okay. Appreciate the awkwardness of Zoom sometimes.
Yeah.
But I really want folks to think about this, because I actually think this is the work you do in your group every day.
It is.
Yeah. So I'm keen on understanding the wisdom. So I'll keep going, and maybe we can revisit at the end there. We've done work with prostate cancer support groups in Canada since the early 2000s. It was the first grant that I ever got in Canada, and it was such a joy, nationally funded, to help us look at the great work you all do. And one of the things we noticed really, we went to all of the groups in British Columbia, and one of the things we noticed that the guys use humour really well, which I think is important to be able to get a conversation about things we don't normally talk about. You do an amazing job of teaching health literacy. When I've been a clinician, I was a clinician for 20 years in an emergency room. And when I first went to groups, I was just so struck by how you talk in numbers, like the PSA, the Gleason, and also that orientation of guys to the health literacy they need to be able to have the conversation with the healthcare professional to be able to make informed decisions. So we wrote about that based on what we saw at the group. We thought you did an amazing job in terms of helping people think about their options in terms of treatment, what the trade-off might be in terms of side effects. We noticed, at least in British Columbia, that a third of the people who went to prostate cancer support groups were women, and we felt that they were like the social glue, but also they did an amazing job of supporting each other, because sometimes the partners, don't get a lot of airtime in terms of working through some of the things and the adjustments that are happening for them. So again, we spoke about that. And we also, polled all of the urologists across Canada to see what their connection with your groups is. And it's strong to say that when a urologist or a prostate cancer specialist endorses a group, or even just mentions the possibility of groups, men are 3 to 4 times more likely to attend a group. So again, I think some of those connections are really well built, and their relationship to groups versus general practitioners' relationships to group, like far and away, specialists know that you're out there and of the great work that you provide. So again, just to say, it's a shout out that I know that you can that you can work with the last scenario and you would know how to talk to a guy. So I'm super interested to hear at the end about, you know, some of the pearls of wisdom you might share that would help us all think about how to get those conversations, because sometimes they're not easy to get. I want to just say a little bit about healthcare as well. We often talk about guys not seeking help. So I often believe when a guy's got prostate cancer and he's in the system and he has specialists working with him around treatment decisions and the aftermath of being treated, we still might be a bit coy and a bit uncertain about other forms of healthcare. And I think mental health is one of those. Like oftentimes, when we audited some of the urologists' charts, you know, they might prescribe an antidepressant, for example, but not necessarily refer to a talk therapy or some kind of specialist mental health care. I think we need to think about that, because this is a big adjustment for guys and their partners when prostate cancer hits. It's just to say that oftentimes too, guys will ask for help or think they're asking for help and either not get it or not be able to quite articulate what's going on for them. So we see a lot of men who come in with somatics, I mean physical kind of ailments, and it's really they're wanting to talk about their mental health, but they don't quite have the ability to do it. And sometimes we absolutely miss the questions that we should be asking. So I'll give you an example. Depression in men manifests quite differently, we believe, to women. So we often see men who are angry, irritable, using substances, risk-taking, over-involvement in kind of sports and work. And so the typical way we'd think about depression showing up would be crying, introspection, low affect. So those things might be there as well, but we're predominantly seeing these other things in men. So I do some work with Simon Rice out of Melbourne University, and we've come up with a male depression risk scale, and it's showing very, very solid results. It talks to all of the things I just mentioned. So we're trying to diagnose depression in men in a different way because we believe they show up angry, irritability, substance use, risk taking. So you can see here, I've just outlined the main kind of items that we ask about in terms of substance, for example. So these whole domains, because we believe if we can diagnose depression better in men, we can think about how to treat. And it's not always medication. A lot of time guys are really good with talk therapy. Anxiety is interesting. The way I differentiate anxiety and depression, uncertainty about the future is anxiety. Regret about the past is depression. And so very simplistic terms, but oftentimes those things can coincide because, especially in a COVID context, we had time. There was a great deal of uncertainty about the future, like when are we getting out of this? When are things going to return to normal? What is the new normal? And we also had this weird time for retrospection, to think back, the could have beens, the should haves, all of those things. Wish I had, because there wasn't enough happening live. So just to say that, you know, anxiety, we also believe manifests slightly differently in guys. We are more likely to pick up anxiety than depression in fellas. There seems to be a bit more of an openness to it. When guys talk to us about anxiety, depression, they talk about stress. They do not talk about depression and anxiety. They say, I've been a bit stressed. And the obligatory thing to do is to ask about, so what's going on? How is that for you? To try and get that conversation. The upshot is that men connect really well by doing. So you're doing the work of prostate cancer, you're doing the work of orientating other guys who are on the journey to the journey, or how it can be. Men's Sheds does a similar thing. It's big in Australia because the government put money behind it. It's growing in Canada, but it's run on volunteerism, much the same as your groups. But it's just to say that it does a great job of connecting guys, because oftentimes the sight unseen stuff that you do, you're great at orientating to prostate cancer, but the other thing that's happening is there's a social connection that's clear as. And it's beautiful because it avoids the isolation. It helps to bring people together. And we know that guys are really good when they connect by doing something, when their core is driven. So again, just to say there's things out there that really help us. One of my favorite things is when I started going to the groups, they often open, especially the group in Victoria here in British Columbia, you know, they'd say to guys when they first came to a group, welcome to the club that nobody wanted to join. And the guys would, you know, kind of talk openly. There's a real way of bringing them into the group. So important. It normalizes a conversation. It gets rid of the one-upmanship we do so often in groups of men where we're kind of competing or jockeying for position. It just stills the waters in a way that you can bring people in to get an authentic conversation. There's one thing that I assure the groups out here about. The leaders will often come to me and they'll say, hey, John, you know, we've still got a core group of guys, but we don't retain men. Like guys come and go, and a lot of them, you know, come to one meeting and maybe not come back. And my assurance to the leaders and to you all is that if a guy can come and get what he needs in one visit, you're providing a very fine service. Not everyone stays, and it's okay. It's great when they do, but if you're providing something that is remedy or elixir, oftentimes people will come and go and they'll bracket their experience. It's okay. It's really okay. It's that the service and the honour continues with the group. So just to say, we believe in community-based work, and we think it's a great de-stressor for men, you know, to have a place to go to. So this article talks to a whole bunch of different, you know, opportunities out there for guys. So I was just in the US, and we had a great conversation about the Black Men's Barbershop. So a place where guys would routinely gather, wait for their haircut, you know, and just kind of shoot the breeze. And what got inserted into many of these barbershops was things about blood sugar levels, where they'd actually take blood sugar levels at the barbershop, you know, get a conversation about how things are tracking, how things are going. Really important conversation with the barbers initiating that. Blood pressure checks, just to kind of not force guys into a space where they might not feel comfortable or be familiar, like professional healthcare, but a kind of a place where they ordinarily go just to kind of transmit some messages. We do the same here. We run a program for veterans who are returning from war or active service. You know, we're a veteran-friendly campus at UBC, so we get a lot of vets in, and we run a veterans transition program. And again, we work with those guys around their language. So they talk about dropping the baggage, you know, unpacking some shit they talk about. And it's important because it's their language. We also recruit guys to this program. It's actually counseling psychology. We'd never call it that, but it's actually, you know, it's a program, and we recruit and we say, hey, you're okay, but there's some guys at the group that could really do with your help. And they show up. They just show up because it's a military code, but I think it's a man's code as well, that we'd always help out other guys. And so they come into that space. So just to say, there are opportunities aside from professional help that can really help guys, and clearly you're in that business. We worry about guys who can't get to a group, you know, that idea that maybe they can't travel, or maybe the Zoom thing is kind of like out of their reach and stuff. So we do offer a website. It's called If I Were Tom, and it's an opportunity to track Tom as he's making decisions, from finding out he's got prostate cancer and working his way through decision making and alike. And it affords the opportunity to make your own decisions. You're just tracking him. He's not telling you what to do by any means, but you're just kind of getting a bit of a sense of the journey, a bit of a visualization. So for guys who can't get to a group and get your expertise, this does an okay job of providing guys with a space. The other one I want to just bring your attention to briefly is a website called Heads Up Guys. It's for guys who experience, you know, or are challenged around mental health, and it offers a whole slew of resources where you can self-evaluate your mood, where you can think about some resources that are embedded in the website. 50% of the people who go to this website, and it attracts 50,000 visitors, unique visitors every month, are women. So, you know, women who want to support guys who might be struggling with mental health. So about 50% of the traffic there. So again, it's got a special spot there for supporters of men who might be challenged, but it's also got lots of direct action stuff for the guys. We talk about sleep, we talk about stress management, social life, physical activity, food, sex and relationship. We cover it kind of all in a way that would just bring you into a conversation that many of us might want to have, but might not always be able to find the avenue to get. Just saying, the traffic to this website has been great. Oftentimes these things, you know, after 5 years, they'll be kind of tapping out, and they might have, you know, had their use by date. This thing has prevailed and actually grown. You can see the tilt there in 2020 when the pandemic hit, and you know, it's interesting. Many folks come to this website and seem to find, you know, some kind of help or a bridge to professional care. So just putting it out there that there might be someone in your life that you think would benefit, or indeed, you know, you might benefit directly. Might be helping out a mate. You know, all those sorts of things. It offers good respite. I want to just briefly talk about relationships, because we don't talk about relationships enough. Movember, who've been a great supporter of the men's health research program here at UBC, came to us and they said, we're really concerned about men's relationships, and we want to better understand how guys, you know, cope with relationships, what sort of strategies they have. And it was really such a wise kind of thing for them to ask about, and it was great work to do. We hadn't thought about it. But if you think in the prostate cancer context, oftentimes relationships are incredibly important, and especially intimate partner relationships, there's shifts, there's changes, and there's adaptations that we've got to do. So just to say, this was an interesting project. One of the guys who we interviewed really early on in the actual research was from Toronto. And George was a 26-year-old African-Canadian man, and he's been living with his girlfriend for 3 years. He loves her very much, and he helps around the house. He does a pretty good job. He kind of says it's equal. However, when George hosts his parents for a meal, he does not help with the meal or any womanly duties. He's got a bit of a problem with that. And he says, you know, I'm just not that courageous. You know, my dad would cut loose on me if he saw me doing that kind of stuff, and he's referring to womanly work. Maybe we'll table it for the end in Q&A. When I spoke to George, I was amazed, right? Because, you know, the sanctity of relationships, a lot of times you don't know what goes on for guys. And I just love a cultural read on this. I'd love to understand what's going on here, you know, and how we think about how we are as role models, or what pressures or what kind of intergenerational aspects of masculinities we might be passing on. I'd just be super keen if you could help me analyse this one, maybe at the end. Relationships are super important. We know that in a good relationship, functional relationship, we know that the mental health benefits are massive for guys. They are in much better places when things are tracking well. By contrast, when something is distressed in a relationship, the mental health issues, they pop. So a man who divorces, that year of separation, that first year of separation, he is 8 times more likely to suicide than a woman who separates. He is also 3 times more likely than the national average of males in Canada to suicide during that period. So we know distressed relationships and relationships that end cause a massive amount of challenges to guys. It's weird, sometimes when we talk to guys, they talk to us about the relationships happening to them. So oftentimes as guys, we'll have objectives, goals related to work, related to what we're doing, you know, but our relationships, we might not have really entirely thought through how they're tracking, what the goals of the relationship are, you know, what's working, what's not. So we can be bystanders, and we can be quite withdrawn within the relationships as well, just to say when we're talking to them. And the vast majority of relationship work is done when there is intimate partner violence or domestic violence. So again, there's very few services around that help us build relationships or maintain relationships. And just a nod to COVID, you know, in British Columbia, we've got a very long line of divorces waiting to go through the courts. One, because the courts slowed down, but two, because there was never, I don't think in history there was ever more pressure on the domestic sphere than putting people into a confined space where they couldn't go to work and they couldn't travel and they couldn't do other things, literally locking them down. I think it put a lot of pressure on relationships, and our divorce rates are very, very high and rising in British Columbia. Just you know, an artifact of perhaps the untold stories so far of COVID. I call them COVID casualties. So what we learned from guys when we spoke to them, they talked about getting a sense of themselves and what they actually wanted within the relationship. And I think that shifts over long-term relationships. I think it shifts over short-term relationships, but certainly in a prostate cancer context, thinking about, you know, how that shifts. So think about me, identity first, and then we, what it means for us. And I think that's something we need to do. A lot of guys talk to us about, you know, a breakup as prompting them to think about me, then we. And it's just unfortunate. There's so much turmoil in breakups that I think if we could just offer something earlier on to guys, we might be in a far better space. And a lot of guys talked about the things they could have done better in relationships, but it was after the relationship ended. So it's about trying to make those adjustments within the context of the relationship. And the one that popped most was definitely about communication. So sometimes we talk about relationships, but we don't talk about the relationship. So we'll talk to our partner and it might be about what we're doing next week, or, you know, where we're going, you know, for a holiday, what the vacation plans are, what's happening with the kids. But we might not actually talk about the relationship and how it's tracking. So again, just that guys talk to us about this idea that perhaps, you know, they'd benefit by a scheduled time to chat through the relationship as what the relationship is tracking, how we're coping, the things I'm enjoying are, the things that I think we could adjust are, the things that could be better are, you know, and having that forthright conversation rather than assumptions, especially when guys get blindsided and they're just taking things for granted or just not aware of someone's maybe discontent within the relationship. Just in terms of help, I think we've stereotyped the help around relationships a bit, that it's going to be some kind of talk therapy every time. Many guys go to the internet. Many people break what I think is code and talk outside the relationship to trusted others, being friends, family, but also find other guys a great refuge to be able to chat about what's happening for them. So I think we've been very narrow in how we've talked about help seeking in relationship, but it's super important. It's really important. When I think about COVID, you know, I think about financial hardship, distressed relationships, job insecurity, and social isolation. You know, it was a pretty abrupt kind of change. I think it's also the transformation back is very, very kind of uncertain. So I don't think any of these things have gone away. We're staring down a recession. We've got really good history of understanding what recessions do for mental health, especially men's mental health, with those pieces around financial hardship, distressed relationships, job insecurity, and social isolation. I call it the perfect storm. And we've polled guys across Canada, and we've got good empirical base to know that the mental health challenges at the moment are really high and rising in the return to whatever the new normal is. So I just want to put it out there that, yes, there's these contexts around prostate cancer, but the world has changed a little bit as well. And so we've got these other things that are happening. It's never just one thing. It's usually a collision of a bunch of things. I think we've endured a very divisive time in terms of how we treat people. In Vancouver, we've had a rise in downtown violence with the lockdown. There's been this divisiveness about masks, this divisiveness about vaccinations and status, about, you know, who did what in terms of vaccinations and all that. It's been really a tough time where we've kind of lost community. And I think that's, that's a bit of a challenge. People often ask me, they say, John, what should I do, if I'm concerned about a guy in my life around his stress levels? I'm borrowing this from Movember. I think it's just great. We call it ALEC. Ask. Literally ask. How you doing? What's going on for you? You seem a bit flat. Where you at? Like, what's going on? What's happening for you? In a concerned way. And then the job is to listen. Like, give them a chance, because you've affirmed that you want to know, and then you just want to give them the chance to talk. The affirmation, the permission, and listen. Just listen. It's not your job to solve the problems, right? You don't want to diagnose him. You don't want to talk to that. You just want to listen. You want to honor his narrative, and then you gently encourage action. It's not your problem to solve, but you're encouraging kind of what's worked for you in the past. Try and get it into a space of, there's some things that have worked for you well in the past. Where are we at with that? How's your sleep? How's your food? How's the diet? Getting some exercise in there. Maybe we can catch up. Maybe we can do something, go for a bit of a walk, connect. And again, that check-in, when a guy discloses and you've listened and you've encouraged action, you must check back in. Because what happens is, a lot of times we're like, oh, I said too much. I disclosed too much, and guys aren't meant to really kind of talk, right? So that notion of coming back into the conversation, it might not be the fully fledged conversation, but it's the affirmation that it's okay, that you have a relationship, that you're able to talk, that you're able to reconnect. So, never be shy on asking or re-asking, and just checking in, and just being there. So it's really, really important, that check-in piece. I'll finish with a few single words. There's a discordant relationship between men's depression, because we diagnose it at half the rate of women, and they suicide at 4 times the rate of women. So that's a discordant relationship. We believe it's related to the difference in the way guys show up with depression and anxiety, that we're not tracking well, that we're not seeing it in ways in which it's actually in front of us, because it doesn't necessarily fit a generic code of, depression, or what we think depression looks like. So there's differences in how we show up when we're a bit flat, depressed, depressive symptoms. And there's diversity within the category of men. So by that, I just simply mean that there's some groups of guys who suffer or are more at risk, live in marginalising conditions. And that can relate to the social determinants of health, money worries. It can relate to ethnicity, Indigenous ancestry, for example, in Canada. Gay and bisexual men oftentimes have a fragile relationship to healthcare. So again, that there's the kind of diversity within who's most affected or most likely to experience depression. Talk about shame a lot. It's almost impossible to talk about shame for guys. It's such a hard thing, but we carry it, and we carry it all the time. And it might be little things, it might be just regrets. Very, very hard. And there's massive stigma. And I talk about stigma as society stigma, but also we carry a lot of self-stigma. If we're not tracking well, not at the top of our game, a lot of times we'll be very, very hard on ourselves. And social isolation, as I kind of mentioned at the front end, it's really hard to connect when you're not feeling great. But guys are so good at being a cushion and being there for each other. There's a lot of peer stuff that works really well. Hacker your groups. Just to say, to be aware of how much you can do as a peer-to-peer. And the point after, my point, I don't know if it happens for you all, but I still get kind of called on, John, you do men's health, what about women's health? And we've always been deeply relational. So we kind of think that if you do men's health well, and you are doing men's health, you are also doing women's health, family health, because it's all connected. So this is a picture of a mum who lost her son to suicide. He was just a teenager. And this is one of the most powerful photographs that we've collected. And she gave us permission to use it to actually give this message. And that is that we, you know, when we do Men's Health Well, and when we make a difference in a man's life, and you can, and we do, then we all benefit, you know, because like, none of these things happen in isolation. We're all deeply connected. I want to thank you all for the opportunity. It's great to get up early and get some sunshine here in the West Coast. It's all blue skies. I appreciate your attendance, and I genuinely want to thank all the folks at Walnut Foundation for the opportunity. I just ask you for one thing. That'd be, we're doing the study that I mentioned, you know, where George, you know, we interviewed George. We're continuing that study, and we're interested in talking to guys who are 19 to 44 years of age about how they build relationships. We think it's really important. There might be guys in your life that would love to talk to us. It's just a Zoom interview where we talk to them about, you know, their relationship. It's been quite amazing. We've interviewed some 60 guys from across the world. So we've been very inclusive about all guys to try and get a sense of that generation. So just a shout out, if there's someone in your life you think might benefit by talking to us, there's a $100 honorarium to honour their time for chatting with us. Just we'd love for you to refer them to us with the details there. And again, just thanks for hearing me out.
Hey, thank you very much, John. That was amazing. There are a number of questions in the chat, so I'm going to ask Nana to read them out, and you can respond to them.
Thanks, Ken.
Go ahead.
Thank you again, Dr. Olive. So the first question is, was there prevalence of anxiety and depression in men with prostate cancer compared with other patients with other cancers? Is there any qualitative difference in the stress between those with low-risk prostate cancer, which virtually is never lethal, versus those with advanced and metastatic cancer? I'll let you answer, then I'll continue.
Okay, what a great question. So it is to say, I'm blanking a little bit on the exact stats, but to say a man with prostate cancer is at heightened risk in comparison to the general male population in Canada for anxiety and depression. Yes. So in terms of getting down to the fidelity of the treatment modalities and where those differences might pop, I don't have that data, but I do know I've read a bunch of things that suggest that ADT, for example, might result in a flatter affect for guys. So it might manifest as depressive symptoms. So again, there probably is some differences around treatment modality and indeed trajectory about where you are on the illness journey with prostate cancer. And I think, you know, it's, we often talk about attribution. So attribution being, you know, can you show cause effect? And I think prostate cancer would be one of the many things that goes on in guys' lives that might be a contributing factor, because we know that as we age, a lot of times we're a little bit more vulnerable to mental health challenges as well. So I'm not, you know, so there is a heightened risk with prostate cancer, yes. There probably is some subtle differences based on treatment modality. And yet these conversations at your group are incredibly important, because the chances are the guys who come into the group are battling. They're probably feeling a bit alone in it. They're probably really juggling with ideas about what it's going to be like, that uncertainty, what comes next, in lots of different spaces. So again, you know, a shout out to the group that you're probably doing this work really well, but it's just a reminder that there would be some need in the folks that are long-standing group members, as well as the guys who are just showing up.
Okay, thank you. There's a follow-up question. Are patients with prostate cancer screened for distress routinely? Do you have that information?
Right. Yeah. So I don't know that they are necessarily screened for depression. It's, you know, or distress. Like, so it's so interesting. We would like it to be the case. Suzanne Chambers out of Australia has argued for the distressed monitor, and just to ask guys about distress, because we think it's more palatable than asking about depression directly or anxiety. Like distress will give us an indicator. Super important. It's not always routinely asked, because sometimes when you're with a specialist, they might be very, very focused on the treatment modality and the prostate cancer, which is fair enough because that's their gig. And they might not ask. That's not to say, but we also might battle to speak up to say, and there's this going on for me. I'm feeling flat. I'm short to temper. Things are not good at home, you know, and we might not find the room for it, and the physician might be focused on something else, and we might not have the referral, you know, to some kind of other areas. And this is specialty work in a lot of ways. So again, I'm not sure that it's typically included, and sometimes it's on us to, you know, ask for the help and find the help, you know, independently, or to maybe raise it, you know, with a specialist to say, hey, there's these things going on. Not easy to do, but not routinely. As far as I know, you know, I couldn't say 100% that it's happening across the country. I'm sure there's physicians who are really great at it and do get it inserted there, but oftentimes it'll be on the guide to speak up.
Okay, thank you. Just a few more questions. What is the prevalence of anxiety and depression in the population, in the general population? And I think you answered a little bit of the last question. How can men with prostate cancer overcome depression or anxiety? Do they need treatment, medication, or can meditation, exercise, etc. be enough? How can we know?
Yeah, so the stats in Canada and the US and Australia is that women are more likely to get diagnosed with depression and anxiety. It runs about 8 to 10% higher. So I think it's roughly 13%, 13 and 15% self-identify. Guys tend to not self-identify, and I think by extension tend not to be diagnosed. So they run at about 7, 8%. So, you know, so there's that sex difference between men and women about who gets diagnosed, who doesn't, who acknowledges or who self-identifies as depressive symptoms and the like. So there is a sex difference there. And like I mentioned, you know, when we think about the typical signs and symptoms of depression and anxiety, I think we're missing some things that we need to pay attention to in guys. They show up differently. As I mentioned, around anger, aggression, substance use. And the second part of your question, just remind me there. Second part of your question was?
Yes. So it was asking, how can men with prostate cancer overcome depression? Do they need treatment, medication, or any other?
Yeah, it's a great question, because there is a differentiation between depressive symptoms and depression, right? Like the clinical diagnosis of depression is usually based on a 2-week kind of loss of interest, oversleeping, or changes in sleep, very low affect, not enjoying the things that you typically enjoy. Like that's an extended period. So that might get you into a diagnosis frame, but depressive symptoms for the everyday, where you're kind of flat, you might be flat one day, a little bit, you know, low on it all, low energy, just quick to temper, that sort of stuff. That's okay. We've got lots and lots of things we can self-manage around that, you know. So social connection is incredibly important. Like, connect with people, even perhaps if you don't feel like it. Like, show up, be there for other people. That's a great way. Meditation, I love. I use the Headspace app. You know, just and it can be like a 30-second, 3-minute kind of thing to just, you know, get you started on your day. Exercise, I can't endorse strongly enough, and it doesn't have to be this whole, you know, 90 minutes or 150 minutes a week. It doesn't have to be that. It just has to be a routine, getting out there. It doesn't have to be high-end exercise. It can be a walk. It can be some company on the walk. It can be some solitary stuff on the walk with the iPods in and listening to something, some music, just some stuff with that. Exercise is so interesting. You know, I still run, 3 days a week, and I'm not breaking any land speed records. Let me tell you, I'm like on the 3-song run, but the best part of my run is the warm down when I'm just walking back, you know, because it helps you just think through things. So all of those things where we're just managing mood are so helpful. So you don't have to jump into professional care. A lot of times you don't have to jump into medications. A lot of guys do really well with talk therapy, just shooting the breeze with someone who's independent of their life, but who they can disclose to in a safe environment. You know, a lot of guys benefit from that. So again, it's just trying to build your team, build your strategies, because we all need it, right? It's, you know, let alone the challenges around, you know, prostate cancer. We all need to sort of pay attention to it, you know, especially I think at the moment.
Okay, and just one more question. I'm going to allow one of the participants to talk.
Sure.
So they will ask their questions directly. Eugene, you can go ahead.
That from Eugene.
Mm-hmm.
Eugene, you have to unmute.
Yeah.
No, I'm sorry. No, I didn't have a question. I'm not sure what happened there with the hand going up.
Okay.
Sorry about that.
I have a question for you. To what extent does understanding the culture of an ethnic group help towards addressing mental issues? The Walnut Foundation has a monthly support group for Black men with the caption, "A safe space for Black men." Is safe and effective positioning for ethnic groups?
Yeah, totally agree, right? So, and I heard you earlier, one of your earlier speakers speak to this in a really nuanced and eloquent way. I think it does matter. You know, there's a sense culturally, a lot of times we don't, you know, we might not even know we're in a cultural kind of space. And there's things that culturally are very familiar and very comforting. And I think that a lot of times, if you're in that space with other guys who intuitively know some of your background and struggles day to day, it can be so helpful because it takes the aloneness, because it's not just, you know, it's not just you going through things. You understand there's people that are experiencing similar, and that there's probably some strategies they might share that would be strength-based. You understand masculinity from a perspective of your cultural and your ancestry, how that works. Because again, you know, when I look at George's narrative, I need your help to undo that, because I think there's cultural aspects to that, to kind of think about where that's coming from, what that pressure might be like, how we role model masculinity and influence other people around us. So long answer to a great question, which is, yeah, it does really matter. We have a club here called the Dudes Club, and it attracts primarily Indigenous men into a space where they, it's downtown east side, so it's a place that's challenged by socioeconomic status and homelessness and the like, but it draws those Indigenous ancestry men into a space, and their mantra is leave the armor at the door and come into the space. It's a safe space, and connect. And I know they draw great benefit from that. Empirically, that it shows, but you can see it when you go to the groups. It's just beautiful because they love connection. Like it brings them back into that cultural ancestry space. And I'm sure it pops for you as well with the group. I'm sure there's a lot of comfort in knowing, you know, there's people around you that share some level of ancestry and insight into the culture. Because the beautiful thing about culture is if you know the rules of a culture, because we have them, you also know how to break them legitimately and for good purpose. So it can be strength-based, that you might transgress a cultural norm that we don't talk much. In this context, it's okay because I got the permission of other guys, and we're breaking code a little bit, but we're getting it done. Yeah.
Okay. Thank you very much. Really appreciate that. Thank you very much, John. Are you going to be sticking around with us?
I'm gonna be popping in and out a little bit,
Okay.
Ken. Yeah, but thank you again for the opportunity and kudos to the work you'll do.
Good morning, everyone. My name is Abiola, and I'm the Secretary for Oladile Foundation. I have the privilege of introducing Dr. Nicole Kolos-Reed this morning. So, Dr. Kolos-Reed is a University of Calgary professor. Is a University of Calgary professor of health and exercise psychology in the Faculty of Kinesiology, adjunct professor in the Department of Oncology in the Kunim School of Medicine, and director of the Health and Wellness Lab and Thrive Center. She holds a research associate appointment with the Department of Psychosocial Resources at the Tom Baker Center, Cancer Center, Alberta Health Services. Dr. Kolos-Reed research takes a multidisciplinary approach to understanding and improving the quality of life of individuals living with and beyond cancer, developing, delivering, and evaluating physical activity program to address the physical and psychological challenges experienced throughout treatment and into survivorship. This research includes national and international collaborations, working with populations with pediatrics to adult population, including those with advanced cancer, and most recently includes Canadian Institute of Health Research, Canadian Cancer Society, CRHRCCS, Cancer Survivorship, Team Grants 2020 to 2026, with additional support from Alberta Cancer Foundation, ACF, to bring our team's exercise oncology program to underserved rural and remote populations across Canada. Dr. Kolos-Reed is a co-founder of Thrive Health, an online education company building capacity in health and fitness professionals to deliver safe and effective exercise oncology resources. As a health behavior change researcher, Dr. Kolos-Reed is passionate about building capacity within cancer care to safely and effectively support individuals with cancer to live well and move more. Ladies and gentlemen, join me in welcoming Dr. Kolos-Reed to this presentation. Thank you.
Thank you very much, Mrs. Olatana. I'm going to share my screen here. Just a second. All righty. So thank you very much for that introduction. It is my pleasure to be here today. Just to confirm, Ken, you can see my screen now?
Yes, I could.
Perfect. Wonderful. So again, thank you very much to Ken and the Walnut Foundation for the invitation to come and talk about exercise and really its role across living well with prostate cancer. Before I begin, I just want to acknowledge that we all live and work within the traditional territories of Indigenous populations. Here in Calgary, that is the Treaty 7 region in Southern Alberta. As well, the city of Calgary is home to the Métis Nation of Alberta, Region 3. And as was mentioned, I am the co-founder of Thrive Health Services. You'll see a little piece on this, but it is a training company, and it's really about building capacity in our communities for fitness and exercise professionals to better serve individuals living with cancer. So as I go forward today, I'm going to cover the evidence, really the so what. Why should we care about exercise? You know, we always just assume, okay, it's exercise, go for a walk, and that's enough. I'm going to show you a bit more about the evidence and really why it is so critical that we integrate exercise into standard cancer care. So the next piece is really then taking that evidence and moving it into practice. And it really is this idea of use it or lose it, and mind the barriers or the gaps that are there. We're traditionally notorious for not being good at taking the evidence that we build through our research and putting it into actual practice. And so within that, I'm going to talk first and foremost about the guidelines, and that's really the first step, along with education, to supporting individuals to move more. And then finally, I'm going to go over resources. So the work that we've done and the focus in my lab is really on moving evidence to practice and building the resources for those living with and beyond cancer. So I will talk about those, including what was mentioned in the introduction, our Cancer Survivorship Team grant that is across Canada and is an option for individuals that may be listening today. Before I get started, I want to simply present what I'm talking about, and that's both physical activity and exercise. So I love that Ken said at the break, hope everybody got up and moved, right? And that's really at the crux of this. We want people to move more during your activities of daily living, right? So I always say when I give talks like this, the best would be if we all had headphones on and we were out walking. And I don't know what the weather's like where you are today, but here in Calgary, it is a gorgeous, sunny, crisp fall day, perfect for getting outside and walking. And so when I talk about physical activity, it is simply the movement you can engage upon during your usual day, whether that's taking the stairs when you get to a building, whether it's parking farther away and walking in, being up and down, not sitting, not being sedentary as much as possible. And then we have exercise, which is a subset of physical activity. And it is really when you're engaging in structured movement for the purpose of health gains. Now, that's not just fitness gains, right? Stronger muscles, better heart functioning, lung functioning, but it is psychosocial gains as well. And you heard a little bit of that in the end of John's talk. I think there was the question on, you know, can you use other things to help with emotional well-being, with depression or anxiety and stress? And we have a lot of evidence that exercise, structured, purposeful movement can enhance psychosocial well-being as much as it does fitness and functional well-being. Okay, so really important that we recognize moving from movement to exercise and the value of both of those. All movement is beneficial, and as I said, I'm going to show you the guidelines, but I want you to keep in mind that simply moving and building a habit of whether it's 5 minutes a day, 10 minutes a day, or 30 minutes a day, as long as you're doing it regularly, there are health benefits, physical and psychosocial, to be gained. And so if you look across just the cancer literature, we've got a ton of evidence, and these are just a couple of the more recent reviews and studies that have been done, really looking at the role of exercise. And so we have thousands of studies, and prostate cancer is our second most studied population after breast cancer in the exercise oncology literature. So here you can see I pulled up some of the titles of, again, just some of the more recent work, because there's been teams that have been doing this for the last 25, 30 years. So you can see some of these titles here, including some reviews as well as position papers on, you know, how do we put this into clinical applications. I can tell you across this evidence, very strong and consistent evidence showing the benefits of exercise for men living with prostate cancer. From everything from, you know, the bottom study you see here, exercise preserving physical function in prostate cancer patients with bone metastases. So even 5 years ago, we would have looked at a man with more advanced prostate cancer who may have bone mets and said, well, let's maybe not have you exercise because of the potential complications and risks, right? The group in Australia that's done this work in Australia really has led a lot of the prostate cancer and exercise work. But they found in this study that men could engage in a multimodal exercise program, and they self-reported higher functioning, and the objective measure of lower body strength was improved with zero increased risk. So zero negative adverse events, zero complications, right? So when we provide exercise in structured environments where it's safe, because there's a lot of other pieces to this before somebody comes into the study, they're assessed and screened, and then we essentially tailor what we're going to be able to give to them, we know we can positively impact outcomes. Okay, so a very powerful tool for function, for overall well-being, for enhancing quality of life. In addition to that, there's really recent research starting to look at the how, the mechanisms. And so this exercise-induced myokines and their effect on prostate cancer is again from the group in Australia. Daniel Galveo and Rob Newton have really led this work, looking at what happens when you exercise. So myokines, they're a cytokine that's released from the muscle, and they can really counter the negative tumor environment, essentially. Now, this isn't my area of expertise. I'm really on the other far end of just clinical application, but this is exciting work, really showing the potential mechanisms, the how that exercise is beneficial, and if it actually changes tumor environments, the opportunities to deliver that exercise during treatment in conjunction with chemotherapy to potentially optimize impacts becomes more established. And so we see again a stronger rationale and role for exercise during treatment as well as post-treatment. So if I'm going to sum up this literature for you, and I could talk to you all day just on this evidence, but the evidence really shows exercise is safe and beneficial for all those living with cancer, including men with prostate cancer, across the continuum. And in prostate cancer, there's work that looks at really pre-treatment, so that the watchful waiting, right? The active phase when men may have elevated tests pre but not being diagnosed. And so really, how do you use exercise to live and be as healthy as possible during that phase? And then really where the bulk of the work has been done is in that treatment and immediate post-treatment phases, where we see multimodal exercises, so different types of exercise programs impact a variety of outcomes ranging from fitness to physical outcomes to clinical markers to psychosocial and overall well-being. And then there's growing areas of research in longer-term survivorship and in advanced populations, so men with metastatic or advanced prostate cancer. And again, in populations where even 5-7 years ago, we didn't really think there would be much we could do in terms of structured exercise. There was maybe movements or gentle forms of exercise, but we're really seeing that it can be safe and possible to have very positive impacts on function, maintaining activities of daily living and enhancing quality of life for men living with advanced cancer. So strong evidence really suggesting that exercise is a crucial part of the cancer journey and is really the key wellness behavior to really integrate into standard cancer care. If we look at some of the outcomes studied, these are some of the ones that I pulled if I did a summary of the prostate cancer and exercise literature. Body composition is a big one, especially for men who go on ADT. And so really exercise along with nutrition is one of our most powerful tools for increasing lean muscle mass and decreasing fat mass. And we know that that can be negatively impacted by the hormone treatments. Treatment-related side effects such as incontinence, right? We know that we can use exercise with a focus on the core to engage the pelvic floor muscle because it is a muscle, and we can strengthen that through core awareness and exercises so that it can help to alleviate that negative impact caused by incontinence. And then the big one, cancer-related fatigue. So this is the #1 negative side effect reported across populations. And we really see that exercise is our absolutely best evidence-based tool. There isn't a pill for fatigue. There isn't a single therapy for fatigue, but exercise is our biggest evidence-based tool. And we did the work. This was led by a team led by Lillian Sung out of Sick Kids Hospital and Princess Margaret Hospital in Toronto. And we did a review of all of the trials, the randomized trials done, looking at the treatments and the potential interventions to reduce fatigue. And we published a series of these reviews. The physical activity review showed the strongest impact. So physical activity reduced across populations and regardless of the type of activity or the duration of the activity. So it could be an aerobic program like walking. It could include some strength-based activities. It could include more mindfulness and yoga movement-based activities as well. All of these showed across the intervention durations from pre to post a reduction in patient-reported fatigue, right? So it's really our best tool that we currently have to alleviate what can be a very distressing symptom and pull people away from engaging in their activities of daily living. And we also know that higher levels of fatigue are related to higher levels of emotional distress. That's stress, anxiety, and depression that John spoke so much about. In addition to all of those kind of here and now, the cancer management, the functioning, the physical and mental well-being benefits, we know there's an actual relationship between physical activity and long-term outcomes, survival outcomes. And what this literature shows in men with prostate cancer is that a modest amount of moderate to vigorous activity. So vigorous activity, I haven't defined it, but that's like you're late for a doctor's appointment, a brisk walk, right? Where you're really pushing your body, that's in that moderate to vigorous range. So when we see men who report 90 minutes to upwards of 3 hours per week, in comparison with men who report being inactive, sedentary, no minutes a week, the active group has a significantly reduced risk of cancer recurrence, cancer mortality, and all-cause mortality in comparison to our inactive population. Okay, so this is true for prostate cancer. The evidence has been gathered from a number of studies, big reviews looking at this associative relationship, as well as across other tumor types. So we have this evidence in breast cancer, we see it in ovarian cancer, for example, colorectal cancer. There's this survival benefit from being physically active. And we know this in the general population as well, right? That leading a physically active lifestyle is associated with living longer, with reduction of chronic conditions, comorbidities. So across the evidence, exercise is safe and potentially beneficial. We know that we can effectively deliver exercise during treatment when we tailor and adjust it to, based on the needs of the populations. And really, when we think about the trajectory of the cancer journey from, in prostate cancer, that watchful waiting or active surveillance stage through to living with an advanced prostate cancer, the benefits of exercise can really depend then on where an individual is on that timeline. So again, prior to treatment, the active surveillance, it can be preparation, it can be maintaining health and function for as long as possible. During treatment, we're looking to use exercise or movement to maintain function and really to alleviate the usual decline that will happen with treatment, right? There's a lot of negative physical, functional, and psychosocial side effects that can happen associated with treatment, and we can alleviate that usual decline to help people then be able to recover better afterwards. And it's really in that after treatment phase that we're looking to improve function, to improve fitness, to improve overall psychosocial and well-being, and with the overall goal of enhancing quality of life. One note on all of this. So all movement's good, whatever you can do and get in and work into your usual lifestyle is fantastic. What the evidence shows, however, is that supervised exercise programs, whether it's individual or group-based, it can be supervised online, as we saw very well during COVID and continues after, or it can be in person. But supervised with a trained professional yields superior results across most of our outcomes in comparison to unsupervised. Okay, so a lot of potential benefits that we see, and really the one caveat is to have that trained fitness professional to really lead the programs. So tons of evidence, right, really showing the necessity of building exercise into standard cancer care. The bad news, however, is we know that we're not getting that translation. Very few cancer survivors report being physically active, especially during treatment. But unfortunately, many of them don't get that activity increase even after treatment. So we know unless we build the support in, unless we make it accessible and help remove some of the barriers, right, we're not seeing people just do it, that Nike slogan, right? It's not just happening. And we know that they tend to remain low longer term, right? If you look across different studies, there's this wide range, 17 to 43%. Of individuals that actually meet physical activity guidelines. And it really depends on the population and what stage they are during treatment or after treatment. But generally, it's bad news. So we've got this discord, right? We've got all of this strong evidence showing that this lifestyle behavior can be very impactful, and yet most individuals are not doing it. Considerations of race in here. So I added in this slide actually after I'd sent my presentation to Ken, but I thought, okay, I'm going to do a quick look and see what has been done to look at this issue. And the big picture is very little has been done. So if you look across the exercise oncology literature, very little work has done anything to look at race. Now, some of the studies looking at access to wellness resources and wellness in different systems has looked more at that race issue. But when I'm talking about physical activity or the associations between exercise, a few studies more in the last like 2 to 3 years have started to come out, but not a lot looking at this. What has been done shows really a mixed bag. Some of these studies show no differences between primarily in these studies, African American and white populations. Those are the two comparison groups. So very little differences across the populations in terms of the determinants of physical activity for these groups or the associations between these groups and exercise in terms of their incidence of prostate cancer. So to date, not a lot. What we do see sometimes the difference is in this bottom study here, the underrepresentation. And so typically in the studies that have been done to date, including across Canada, there's an underrepresentation of ethnic populations in general. So we see a white majority population, which isn't representative of the overall population. The work in our lab has started to actually address this. We've done work in South Asian populations, and we're doing work in sexual minority populations right now. But very little has really taken into consideration everything from the front end of how do we interest this population to come into our studies and into our programs, right? To then looking at the potential impact of race on different outcomes. So a lot of work still to be done. And one of the, I guess, caveats in all of this literature for you to consider. But in general, we know mechanisms-wise, exercise impacts-wise, there is no difference across races, right? Exercise is good for all of us. So I love this picture because this really summarizes where we're at right now, right? All of the evidence is not making it into practice, which is really unfortunate because exercise is so good across different outcomes. As I said earlier in research, we're renowned for having what we call the 17-year gap of moving research evidence into practice. And I have worked very hard across our career, my career here, and within the collaborative teams that we've built across Canada to start to address this, to really take that evidence and move it into practice and then to study it in the real world. So the first step is cancer exercise guidelines, right? And I want you to take a look at these guidelines, but with a strong caveat that as you look at these, recognize that even 5 to 10 minutes a day of regular movement can provide benefits. So the guidelines are great. They're based on, here's a summary of the evidence where we optimize health benefits from exercise, right? And you can see here, there's aerobic types of exercise. So that's your walking, your swimming, your cycling, anything that gets your heart rate elevated, you're working your lungs, your cardiovascular system. Then we have strength training. And I can tell you the evidence is very clear for men with prostate cancer. Strength training adds benefits above and beyond aerobic activity. Okay, so we really, if you look across the prostate cancer and exercise literature, you often see multimodal exercise programs, HIIT, high intensity interval training programs, and or just resistance training programs because of that importance in outcomes from strength training. So that's working your major muscle groups. And then we have flexibility guidelines, stretching, right? And I always tell, I do a talk every 2 weeks for our prostate cancer center here in Calgary. And I always say on your tired day, on your busiest day, on your day where you're like, I am not getting that walk in, I'm not doing anything else, stretch, okay? Do a nice session where you focus on your breath, where you focus on scanning your body from the top of the head to the tip of the toes to see how does that feel? Where are you holding tension in your body? And can you just gently move around those zones, whether it's for many of us in our neck and our shoulders, stretch it out, right? Simply doing that on a daily basis can afford benefits. Okay, so in moving evidence to practice, these guidelines are great because they give us a target. They give us a really starting place to have the discussion about exercise. Okay, but if that's all we did, if we just went to the guidelines, you know, we're missing a lot of people who the guidelines don't work for them. It's too much. It's seen as, you know, a barrier more than something that can facilitate them going. And then that's where the recommendations that are within the guidelines become important. And in particular, this bottom point, right, that we have to individualize and tailor. So we can't actually take what you just saw, right, these guidelines and just say, everybody go do this, because this doesn't work for everybody that's out there. Rather, individualizing and tailoring. So in any of the exercise programs that we've built and the studies that we do, this is the key point, is we bring individuals in and we meet them where they're at. You're going to see that with the example I have coming up of the Excel study. Okay, so these are the recommendation statements, and it's really this last one that we can't just use the guidelines as a general, hey, everybody go and do this, but we have to take each person and offer them a tailored supported program to really optimize outcomes and benefits. That's where step 2 comes in, this mind this gap knowledge translation piece, exercise oncology resources, and that's really the focus of the work that we have done in building these resources that are available for all of you. And so I'm going to share our educational resources and then our programming resources. So we have a couple websites that you can go to and everything is free. So you can go there and download these. You can move them, take resources and put them on your own websites. These are there to share. And we have worksheets, we have infographics, we've got a ton of educational resources that can really get you started to think about what can you tap into to help support your health behavior change, right? So it's taking our best evidence and putting it into hopefully visual and graphic summaries that you can use, that you can share with others, that you can use to facilitate discussions and support around the behavior change. One guide that I think has been really well done is our Thriver manual. And so this is a free downloadable PDF, which kind of summarizes everything. And right now we're actually working on tumor specific supplements to this manual. So we've just finished our breast one, our prostate one will be out in a couple weeks. We have an advanced cancer one. We've got across different tumor groups. But this is an excellent manual. It's available on the same website, Thrive Health Services, which is our educational website. And you can find this there under all of the Survivor or Thriver tabs that have got this. So again, you can download this. It's a very well written, evidence-based wellness manual that introduces all of these ideas and really where the evidence is and the practical pieces. What can you do? How can you take control of your wellness during your cancer journey by even making small changes, little changes that can have a big impact? So an excellent resource that again is free for you to download. And then the last piece around the education is really what we do mostly within our programs. We call our programs Exercise and Educate, because it's not just an exercise prescription. It's really supporting this idea of moving more. And what does that look like, even if you start with 5 minutes of exercise every day? And these are some of our key messages. And I took this slide actually right from what I teach to the men at the Prostate Cancer Center every 2 weeks. Number one is you listen to your body because you're the best expert in your body, right? And so find what feels good for you. And that is what's going to help you build the habit of doing it, whether it's 5 minutes a day or 30 minutes a day, right? So do what feels good for your body and move your body. Our bodies are built to be moving, right? And so as much as possible, find what feels good and do. There isn't a single best exercise. I always get asked, can I do this? Can I try that? If it feels good for your body, after surgery's healing process, we have guidelines around waiting post-surgery. There's a wait period. We want you to move but not engage in structured exercise during that time. Okay, but there isn't a single best exercise. There's not a single best time to exercise. Okay, the best exercise is the one that you're going to do on a regular basis. That's what it is, right? So if you love to cycle, you can get back to cycling. If you love hockey, if you love walking, if you want to get out for hikes, all of those are great options, okay? There's 2 big factors that we know will absolutely help people develop that habit of exercise, and that's really what we're going for. And the first is social support. So we know that when you've got support, whether it is people that you're doing the activity with, or whether it is that supervised session, right? The exercise professional that's there supporting you, we know you're much more likely to build that habit and maintain exercise. Because here's the big picture message is really, unless you do this on a regular basis, you don't get the benefits. It's just like brushing your teeth, right? You can't do it once in a while and expect to have healthy teeth. Same with exercise, right? So again, just think about what can you do 5 to 10 minutes a day if that's where you're starting, right? What is feasible in your lifestyle to simply make that small commitment to? Because all of us have 5 to 10 minutes, okay? And how do you build the support for that? And then the flip side of that is, well, what's stopping you right now, right? During COVID, we saw that people didn't have access to anything, right? There was a real physical barrier, right? We were all isolated. We didn't have access. Everything was closed down. So that access issue can be a big one for lots of people, even post-COVID, as we start to go back to normal. Okay, but what do you enjoy? Again, we're not built to keep doing things that we don't like. That becomes easy to find excuses to then not do it, right? So find something you enjoy, find something that fits into your lifestyle that's sustainable. Okay, so this educational piece around behavior change is really critical to supporting people tend to make the actual change. When we talk about then those barriers, we know that there's a lot of things that people talk about, right? Lack of time is the #1 barrier for all of us when we say why we don't exercise. Okay, so I encourage you to break it down. You can have what we call exercise snacks during your day. It could be getting up, it's a gorgeous day and you just take 5 minutes to go outside and get a little walk in, right? Or you go outside and you do some deep breathing activity and stretch your body, right? Just for 5 minutes, right? That's a big one for many individuals, but if you break it down, you can build up your minutes over the course of a day. Many individuals don't know what's safe for them during treatment, especially and after treatment, or if you're living with an advanced cancer, right? What is safe? Can I do this? And that worry can stop many individuals. And so that's why having a program where you've got a trained fitness professional can be really critical as well. The other piece within our education that we embed in our programs is this idea of giving people the skills, right? The skills to be able to support your health behavior change. Right? Whether that's exercise or whether it's nutrition changes or sleep changes, right? These lifestyle behaviors are all so important. And we talk about these different elements. So I'm very briefly going to share with you the resources that we use and the education that we provide. And then I'm going to share with you our program that we have. So goal setting. This is the big one. It's our most evidence-based exercise behavior change tool that we have. And we encourage people not just to set a big goal, and you can have that big long-term goal, that's totally fine, but break it down to your weekly goal or even your daily goal. In our programs, we often ask people, what got you to class today? And what are you looking to get out of your class today? Right? Having that daily goal can be very empowering and motivating, right? It can, because you can see the change right away. Did I get to my daily goal or not? Okay, I can adjust it. You might have heard SMART goals before. We have a little bit of a modified version of a SMART goal. So you want to set your goals as specific as possible. You want to be able to measure them. So how do you know if you've achieved your goal? Okay, you want to choose goals that are attainable, challenging, but within your reach. Because if you never reach them, then the whole purpose of using goals to motivate you doesn't happen, right? And then we've got 2 R's and 2 T's. So it's relevant and realistic for you. So you want to choose something that's that you can, connect with. It's part of your identity, right? So relevant and realistic for you. And then the big one for us, timely. So there's always time frames around our goals, whether it's daily or weekly or longer. And then build that social support element in together. Who's going to support you in your goal? It might be just someone you tell your goal about, or it could be somebody that is sharing the goal with you, right? And we know when we can foster that more dyadic support, whether it's a partner at home, whether it's a group exercise class and other people in the class, or whether it's a trainer with you, when you have, again, that social support, you're much more likely to be held accountable to your goals. The next behavior change skill that we teach is how do you put it into action planning, okay? Sometimes called planning implementation. This is really an important skill, especially when this is a new behavior, right? So if you're just starting to build this up, we know that this can be super relevant to plan, to be able to schedule, to update your goals, update your activities, and to track things. So we know when we do this effectively, it can increase your confidence because you can see, you can track, right? Hard copy, or you can have it digitally, whatever works for you. And you can build into this then your goal setting, and then that feedback and reward system can be really built in so that you can adjust your action planning over time. This can be simple. It can be simply that you write in, okay, on Monday, Wednesday, and Friday, I'm getting in a 10-minute morning walk, and it's in your calendar, right? You think about your doctor's appointments, they're in your calendar so you don't miss them, right? They're prioritized. Action planning is about prioritizing your wellness in your usual schedule, whatever that looks like for you, right? And so here's an example of scheduling exercise based on your planning, and it can be as simple as a calendar like this that you can print out and put on your bathroom mirror or your kitchen fridge, somewhere where you see it, right? And so you just simply put in, what are you going to do each day? On the bottom, you can have some more specifics about, well, what are the things I want to do, I like to do? What are your goals over the next 3 months, or it can be a month, or it can be that week? And then how does physical activity make you feel? Right? Again, we're going for always feeling good, and you're going to see what we track in our actual program in a minute, but physical activity is something that should enhance your sense of well-being. You feel in control. And that's one of the central elements, I believe, in how exercise is so beneficial, is it can help give people back that sense of control that cancer sometimes takes away, right? Because it's something that you get to choose to do that can enhance your overall wellness. So as you plan, a big tool to, again, it goes hand in hand with goal setting, is to self-monitor, right? And to adjust what you planned, and then to adjust your goals to address the barriers that are inevitably going to come up that we already talked about. I showed you all those different barriers: the lack of time, the lack of access, all of a sudden you're not feeling well during your journey, and physical changes can be a barrier, right? So self-monitoring and tracking your progress over time, whether that's weekly or bi-weekly, helps you then to be more accountable and to deal with the barriers as they come up, versus, oh, here's this barrier, I had to stop for a bit, and now I can't do this, right? That all or none mentality. And so really the self-monitoring acknowledges that barriers are happening for all of us, right? We all have life that happens around everything else. And sometimes that life can disrupt even our best intentioned plans. And so having this tracking and self-monitoring can be really critical to helping you get back on track when a barrier can take you off track. This has already been mentioned, but again, I cannot underemphasize the importance of social support in this behavior change process. We know participants are more likely to be successful in maintaining healthy habits if they build that network of support, whoever and whatever it can look like, and recognition that there's all sorts of types of support that can happen. It can be instrumental, so somebody actually showing you the new exercise, training you, right? It can be that informational support, so providing education, those handouts and worksheets can be very supportive. The companionship piece, right? The having other people to exercise with, the walking partner, the group fitness class that you become accountable to. Or it can be other things like emotional support, somebody checking in. You know, John used the ALEC framework for how to have discussions, and the emotional support that comes from group environments and exercise classes can be as critical and as important for our participants as the actual physical changes and the physical that they get out of the actual program, right? The last educational resource that I want to share, well, it's moving into the practice stuff, is our actual videos that are there, right? So we used to have a prostate-specific website. It was actually funded by the Movember Foundation. It was True North Lifestyle Management, and I was the lead for that across Canada for the last number of years. That website is no longer active, and so we're in the process of moving all our prostate-specific resources to this website as well. But this is our website at the University of Calgary, thriveforcancersurvivors.com. There's a YouTube channel on our website, so you can go on and see 10 weeks of our 12-week program and just do it from home online. And it's all free. There's no charge to come into any of these resources. There's educational resources out here, and then there's short video clips showing you different exercises and how you can adjust it, whether it's in a chair or it's with bands or weights, or it's just your own body weight. So a lot of excellent videos here, and these are all led by trained, qualified exercise professionals, right? So people in our team that have been trained and lead our classes with individuals with cancer on an ongoing basis. So lots here that you can tap into and access, and I encourage you to check out the website and the YouTube channel on our site. Okay, so to wrap up, I want to tell you about an excellent, I think, program that we've had funded that is available across Canada. So no matter where you are listening from today, the EXCEL program is an option for you. So EXCEL, Exercise for Cancer to Enhance Living Well, has been funded by the Canadian Institutes of Health Research, Canadian Cancer Society, and in Alberta is also supported by the Alberta Cancer Foundation. This is a cancer survivorship team grant. So we're one of 6 that were funded across the country. And this is really a program that has been designed to take what we've done in Alberta for the last 6 years very successfully across the province and build it out across Canada to really reach people outside of major urban settings. So that's the one caveat, because in many of our urban settings, there are exercise oncology resources. However, outside of those settings, there's often not any resources available. And so Excel is primarily delivered online via Zoom, other than in the Maritimes, where we've had the opportunity to build more communities with actual in-class programs. So Excel is available to anyone, not just prostate cancer, but anyone with a cancer diagnosis living outside of major urban centers, up to 3 years post-treatment. So there's a large window for being able to capture individuals to come into the Excel program. It's for adults, and again, one of the limitations in lots of our research is you have to be able to consent in English. We screen you when you come in, right? So if you're interested in the program, the first piece is a whole screening phone call and or questionnaire to make sure you're eligible and you can participate safely in physical activity. And then because it's primarily delivered online, you have to have internet access and be able to have a device with a video function, have the camera, because we have to have cameras on for safety during our exercise programs. Okay, so that's the eligibility. Well, if somebody's interested in Excel, once they contact us, you're screened, as I've said, by a clinical exercise physiologist. So that's someone who has the scope of practice to safely and effectively assess you and then determine which class you can go into, because we've got more advanced classes for people living with more advanced cancers, people that are under treatment, people that maybe have comorbidities and complications that have an impact on their exercise. And then we have classes for people that are pretty much could go to someplace in their community, but they want a cancer specific resource, right? We help you get the medical clearance if we need it. And if you are a higher risk group, you would be in a program led by our clinical exercise physiologist. And you can see on the screen here, this is essentially what the classes look like because they're online via Zoom, right? So you see your instructor there pinned for you. This is a picture showing everybody here, but you see, you just need some space, right? You need space in your home, outside, wherever you're going to access it from to be able to engage in the program. You can have weights or bands, but you don't need any equipment. You just need your space and your ability to move. What you get in Excel, so Excel is a study, right? And the exercise intervention, everything is free. It's a 12-week group-based program. So you get 2 sessions a week that are 1 hour each. It's a circuit-style multimodal program, meaning that you're going to get some aerobic activities. So you might do brisk walking or high knees or jumping jacks, depending again on your level. You're going to get a lot of functional movement. So a lot of working your major muscle groups. You get some core training and you get balance and stretching. So it's really an all-encompassing program that's delivered again online. So you have a lead instructor, and then there are support people on the session as well to monitor for safety, right? So the big piece in delivering this is safety first, ensuring everybody's got a good setup and that we've got all the screening in place to make sure you're in the right class. And then it's give you the program to get the benefits. Right, so the moderator is there on the class with the instructor to make sure that everybody is safe during the program. You're given the skills of the exercise and educate piece that I've already mentioned, but you're also, tracked during the session. So we use this rating of perceived exertion to really understand, and where does it feel comfortable for you to work intensity-wise. So while everybody's in the same class, everybody's working really at levels that are appropriate to their fitness and to their well-being, right? So we use this 0 to 10 scale instead of taking, heart rates or having the smart watches on. We can use this scale to really monitor people's intensity. The other thing that we do is use these energy and fatigue thermometers. So these are an excellent tool, whether you're in a program or you just want to use these on a regular basis. Every time you move more, your energy should go up and your fatigue should come down. Okay, so you may not want to move. You might be like, oh, I've had a long day. I've driven to appointments. I've been stuck in traffic in Toronto, whatever it is, right? You might not want to move, and your energy and fatigue might be, low energy and higher fatigue as you start. The goal with movement, whether it's a 10-minute walk, get out for some fresh air, or you're doing a class, is that you see that switch. Energy goes up as you move more, and your fatigue comes down. Okay, so these are great tools for you to use just on a regular basis, and then we use them in the Excel program. We also, you've seen this slide already, we embed our exercise and educate framework. So Excel is much more than just the 2 classes a week. It is discussion around behavior change, it's handouts and the resources, and it's additional webinars. So we have webinars that all of our participants attend to learn more and to really facilitate that discussion and connection with others. You know, we get asked a lot of questions when people find out about Excel and can they do that, and they're on treatment and I've got a bad hip, I can't move as well, you know, and so I just want to clarify that really, while this is a group program and it's a protocol study, it's about tailoring to meet people where they are at, okay? So we take into consideration your previous experience with exercise, your current fitness level, the treatment effects, other comorbidities, a bad hip, a knee replacement, heart disease, whatever it might be, what equipment you have, what kind of space you have, and then we modify the program based on assessing you at baseline and then delivering the program to you for the 12 weeks, right? So it's really tailored to meet individuals where they're at. And I'm going to end with these quotes because I think they so nicely capture that it's not just about the exercise prescription. Across all of the resources we've built and the programs that we lead, it's very clear that while the exercise is a means to gather everybody, the gathering of individuals and building this sense of community and support is absolutely an essential part of why we see the benefits across, in particular, the psychosocial well-being, the mental and emotional well-being of our participants and their overall quality of life. Right? So it is about empowering individuals to really integrate wellness into the cancer journey. And so with that, I thank you again for the invite to speak with you today. I believe that exercise really must become part and parcel of standard cancer care. And I look forward to any questions. And if you want to reach out to us, our wellness lab at UCalgary is definitely the best way via email. Thank you.
Thank you. Nicole, the YouTube link and those links, can you put them into the chat for everyone? So
Sure, I should be able to do that. Yeah.
For you, thing.
I can, yes.
And while you do that, I have a question.
Mm-hmm.
So the Walnut Foundation does a lot of presentations to church and community groups.
Mm-hmm.
One of the questions that we always get, especially from younger men, is I'm potentially at risk because of my grandfather within the family.
Mm-hmm.
What exercises do I need to do to either slow the progression or prevent me from getting prostate cancer, being diagnosed?
Yeah, you know, that's an excellent question. And just like there's not a single best exercise, there's not, you know, hey, do this to prevent any type of cancer. We know it's about so much more than that, right? Cancers can impact somebody who's been very physically active. We do know there's that association though, right, between inactivity and increased risk across all populations, right, for cancer risk. Across many of our cancer types, we see that strong relationship in terms of prevention. And so the best thing you can do to reduce your risk is just simply be physically active. Right. And if you can try to reach those guidelines of around 90 minutes a week, the Canadian physical activity guidelines for adults is actually 150 minutes a week. Right. But really, we tend to see benefits and risk reduction anywhere at the 90 to 120 minutes is where we start to see it. So maintaining a physically active lifestyle and then along with other protective behaviors, right? Stress reduction, getting enough sleep, good nutrition, those all work part and parcel for that prevention piece. And sorry, was there another part, Ken, there too, if there is cancer?
So the other part of it is, so a man has just been diagnosed with prostate cancer. And we know the person goes through a lot of mental stress on a diagnosis. You know, what is going to happen to my life afterwards? And they're worrying about all the impact of it. How do we motivate them to actually start taking that responsibility, shifting from the why me syndrome to really taking responsibility to do the next step, which is I've got to take control of this and do something about it?
Yes. So the key is what you just said, and it's that control, right? So when we think about exercise, as well as other lifestyle behaviors, we have this category of modifiable lifestyle behaviors, right? Meaning modifiable, you're able to change them. The evidence that I shared around the benefits of exercise for individuals living with and beyond cancer, the good news is you can start at any point, right? It doesn't really matter once you have cancer what you did before in terms of then accruing the benefits of being physically active, right? So you can be 2 years past, have gone through that, oh, why me? I'm depressed, I'm anxious, I'm stressed, right? All of that. At any point in time, if you start by making small changes, again, getting 5 to 10 minutes in a day, you start to accrue the benefits, right? So yes, if you can start earlier, we know we can help to diminish many of the negative side effects before they become bigger issues, but you can start later. And so I think the pieces that we really recognize is that, you know, typically when we think about people engaging in behavior change, we point at individuals, right? We say, well, it's all up to you. We know that doesn't work, right? It puts a lot of pressure, and frankly, our systems around those individuals put up a lot of barriers to them becoming more physically active, right? So I believe the healthcare system, the cancer care systems, need to start to embed the support for individuals to tap into these lifestyle behaviors like exercise in a more systematic way. So we don't leave it up just to you to figure it out and do it on your own. Because when you're sick, when you're dealing with lots of stress, when you're emotionally drained, it's not easy. It's not easy at the best of times to maintain a physically active lifestyle, right? And so we added cancer diagnosis and treatments and all the negative effects on top. And I think it's important to recognize it's not easy to make the changes. It's not that it's just exercise, right? If it was just exercise, everybody would already be doing it and you wouldn't need me to talk to you today. We wouldn't need programs like Excel, but we absolutely need Excel. We need Excel embedded into healthcare systems so that men hear about it sooner. And I think the nice thing in particular for men with exercise is that, you know, it provides an environment where you're not focused on just talking to other people, which oftentimes men have a harder time with, right? And that support group. Our exercise is a moving support group, right? So we have the opportunity to pull men together. And I didn't mention this, but the work we've done in Alberta, we established men's exercise groups, prostate-specific groups through our True North programming. In Alberta, we have men's only exercise classes. So that we can bring those men together to help them to connect, to really sometimes address some of the concerns that they have that they don't want to share in mixed groups. And so that's been pretty powerful as well. So I think it does, if we can get people started and have a system that supports them to get started, we're much more likely to help them gain back that sense of control that cancer takes away.
Okay. Thank you. I don't know if there are any questions in the chat. Anna, are there any questions?
No questions at this time.
Okay. Thank you very much, Nicole. The Walnut Foundation is going to look more into this Thrive Health Services and the stuff that we can sort of partner with you with in the future. It's been a long day, but it's all been very, very good stuff for us. Our last speaker is very important to us. It's Dr. Mike Fraser, who is the Director of Cancer Program Implementation at Movember Canada. Movember, I should let you know, is one of the sponsors of this particular program. And we really do appreciate Movember for assisting us with this conference today. Let me just read Mike's bio and then he can go into what Movember is doing. So Dr. Mike Fraser obtained his PhD degree in cellular and molecular medicine at the University of Ottawa and completed postdoctoral studies under Dr. Rob Bristow in the radiation medicine program at Princess Margaret Cancer Center. Dr. Fraser previously served as the scientific director of the Canadian Prostate Cancer Genome Network, one of the largest prostate cancer whole genome sequencing programs in the world. He also served as director, prostate cancer program at the Ontario Institute for Cancer Research and was a founding member of the International Cancer Genome Consortium, Pan-Prostate Cancer Group, a multinational effort to characterize the genome of prostate cancer and to develop molecular biomarkers of aggressive disease. Prior to joining Movember Canada in July 2020, Dr. Fraser was a staff scientist at the Princess Margaret Cancer Centre and an assistant professor in the Division of Urology, Faculty of Medicine at the University of Toronto. Dr. Fraser has published over 60 research papers, review articles, and textbook chapters in the areas of prostate cancer genomics and bioinformatics. In 2018, he was named the Next Gen Star of the American Association of Cancer Research, and he is the recipient of numerous local, national, and international awards for research and teaching. So I'd like to introduce Dr. Mike Fraser. Mike, good to have you.
Thanks, Ken. Thanks, great to be here. Thank you so much for having me.
I just got to make you a co-host.
Okay.
There you go.
Okay, and just make sure I share the right screen so you don't see all my terrible mess. There we go. And okay, can you see that?
Yes.
Okay, great, perfect. So first of all, again, thanks so much, Ken, for the invitation to speak with you all today. It's a huge honor. You know, this group does such important work, and it's a cause that's very dear to Movember and to me personally. So I'm going to talk a little bit today about some of the work that we've done at Movember in terms of the work that we funded around prostate cancer biomedical research predominantly, although I'll touch a little bit on some of the programs like True North that you just heard about, but I'll focus mainly on the biomedical side. But really what I want to talk about today is to discuss where we're going. We're going through a period of transition at Movember. It's all good. It's a very good thing. You know, we're growing as an organization in terms of our cause areas, but also our scope and hopefully our impact as well. So I want to talk to you about sort of the way in which we'll be implementing some of those changes over the coming, let's say, 5 to 10 years. So yeah, I've said global reach for local impact, and I hope you'll see what I mean by that. So I'll just start with a quick land acknowledgement. Movember acknowledges that we are gathered on the ancestral lands, treaty lands, and territories of the Indigenous peoples of Turtle Island and pay tribute to their legacy and the legacy of all First Peoples of Turtle Island. Movember respects and acknowledges harms and mistakes of the past, and we dedicate ourselves to collaborate in partnership with First Nations, Métis, and Inuit people in the spirit of reconciliation. So I won't go through my own background. Ken just did a great job of that. I'm not going to talk to you about any of the cool science that I've done in the past, with one small exception. But we'll talk about really more about Movember and where they're going. So this won't be news to you, but I thought just to put everybody on the same page, I talked just a little bit about some of the things that are going to be relevant. We talk about prostate cancer, of course. 1 in 8 men in Canada will get prostate cancer in their lifetime. These are new updated numbers from the Canadian Cancer Society showing about just a little over 24,000 cases a year and over 4,000 deaths. Of course, it's a disease that is predominantly in men over 50 years of age. You know, nothing predominantly new here. Of course, you see that spike in the early 90s with the introduction of PSA testing. When prostate cancer is diagnosed, there are a number of challenges that exist really along the continuum of the disease, and really the goal of research and basic and clinical research is really to address one or more of these challenges. At the population level, we talk about things like screening. Can we identify tests that are more accurate than PSA, for example? Can we reduce the potential harms of screening? By that, I mean things like biopsy and the complications associated with biopsy, and really about detecting what are clinically significant cancers. In Canada, as in most Western countries, the disease is most often diagnosed in stage 1 or 2 or localized with no evidence of spread outside of the gland itself. These prostate cancers get get stratified into low, intermediate, or high risk based on a number of their characteristics. And there are clinical challenges associated with each of those groupings. So in low risk disease, for example, we really want to try to minimize overtreatment. We want to identify those cancers that are really indolent and don't require aggressive treatment. And conversely, we want to identify those few cases that are uncommonly aggressive and actually do need to be treated more aggressively than might otherwise be the case. In intermediate risk disease, we have this ongoing problem of how do you distinguish between indolent and aggressive disease. And in high risk disease, that goal there is really to prevent progression or at least delay progression to local or distant metastatic disease. This is the disease that is going to be become life-threatening potentially. We talk about advanced prostate cancer, either that develops from progression of localized disease or that is diagnosed as quote unquote de novo metastatic disease. We really have a number of clinical challenges. For locally advanced disease, we want to again prevent or delay progression, similar to what we see in the high risk setting. Oligometastatic prostate cancer, which is sort of an emerging area of interest, where you have metastatic disease, you have spread of the cancer, but it's only in a few spots in the body and probably represents the potential last step where the disease can be cured. And there's evidence to suggest that targeted radiation can be very helpful there. So again, we want to be able to prevent progression to distant metastatic disease. And when we talk about distant metastatic disease, or what's commonly called metastatic castration-resistant prostate cancer, we're talking there about increasing not just length of life, but really about what are called quality adjusted life years. We want to prolong life, but we want to improve the quality of life over those years as well. So there's challenges that exist at all of these levels. And like any funding agency or advocacy group, we have to pick and choose where the potential biggest impact is for men across the spectrum. There is an emerging challenge that's really over the last, this is some data from the Canadian government, but really showing over the last 15 years or so, there's been this increase in the diagnosis of disease in stage 3 or 4. It still represents a very small proportion of the cases compared to stage 1 and 2. But if you look back in 2011, only 8% of the cases were being diagnosed as stage 4, and that is basically metastatic at diagnosis, whereas the latest numbers we have are from 2017 are, almost 13% now. So it's a 39, almost 40% increase in the percentage of cases that are being diagnosed at that stage, and that's largely because screening programs have dropped in prevalence. People are not taking advantage of screening programs. There's a number of other issues there, but this is a major problem. This is the disease that's potentially life-threatening, and we want to make sure that we're minimizing the number of men who are being diagnosed at this stage of their disease. The bottom line, is that there's no average prostate cancer. There's no single prostate cancer. Every cancer is unique, and it's up to us and up to researchers, like you've heard today, to understand what those differences are and to leverage them to make sure that men are getting the best treatment that they can and living the longest, fullest, healthiest lives they can after a diagnosis of prostate cancer. So again, just to summarize, at Movember, our goals really are, our primary goal in the space of prostate cancer is really to reduce that burden. Reduce the burden of prostate cancer in Canada? And by that we mean reduce the number of cases being diagnosed, reduce the number of men who are experiencing adverse side effects, reduce the number of men who are dying of the disease. And prostate cancer is such a big problem. It's such a prevalent disease. The number 1 diagnosed male malignancy in Canada, and again in most Western countries. It requires partnerships and it requires community building, not just of researchers and clinicians, but of men and their families who are living with prostate cancer, to understand the disease, understand the intricacies of how the disease interacts with things like socioeconomic conditions and race and all of those sorts of things that influence the way a man experiences his clinical journey and the way their family experiences that clinical journey as well. And so before I talk a little bit more about where we're going, I'd like to just kind of review quickly where we've been, because I think it sheds some light on some of the successes we've had, but also some of the challenges and some of the areas for improvement that we see as an organization. So just to put things in context, if you look at prostate cancer research in Canada, Movember started funding prostate cancer research in Canada in 2008. Since that time, it is the second largest funder of prostate cancer research, behind only the federal government, the Canadian Institutes for Health Research, or CIHR. And Movember has funded over $107 million worth of research projects across Canada in that time. So to put that in context, that's 1 out of every $5 invested in prostate cancer research since 2008 has come from Movember. And I think that's something that I think people perhaps don't appreciate, because traditionally Movember has been very much we come out, sort of mid-October, right around now, and we kind of go away in mid-December after the fun of growing the mustache has gone away. And I think a lot of people perhaps don't understand where that money goes, actually, or the extent to which that money is doing incredible work. And so this sort of, I think, puts it in context of the countrywide investment that's been made in the context of prostate cancer research. So what results have we seen as an organization? We've seen them right across the prostate cancer journey, as I've termed it. We've seen revolutions in our understanding of the basic biology of prostate cancer. We've identified new ways that we can identify and treat men with the most common forms of prostate cancer. So with localized disease in the so-called translational science space. We've initiated trials to look at modern imaging tools, and I'll talk about one of those in just a minute, to identify recurrent prostate cancer and improve how we deliver radiotherapy. We've funded a lot of trials that look at how chemotherapy drugs and anti-androgen drugs and ADT are spaced out and sequenced in the advanced cancer setting. Through programs like True North and Ironman, we've worked hard on clinical quality and survivorship programs. Our partnership with organizations like the Walnut Foundation, I think, are typical of this, right? And this is an area that over the next few years, as you'll see, we're hoping to get much more involved in as we move forward. We've looked at health economics. So how do you implement some of these new therapies, these new drugs, the new screening tools within the context of a single payer system like we have here in Canada? And at the same time, trying to understand, the etiology of the disease, what causes it, how can we prevent it, what are strategies to understand the distribution of the disease and how factors that perhaps are non-biological can influence prostate cancer incidences and outcomes. So I'll talk quickly about two such success stories in my view. Full disclosure, I'm a little bit biased. I had the pleasure for a number of years to work on the Canadian Prostate Cancer Genome Network and ultimately to lead it for a few years. This was a program which was the largest single investment that Movember has made in a single research project anywhere in the world. It was a very large, generous donation that made this all possible. And really, it was a project that was aimed at understanding not just what are the changes in the tumor DNA and the tumor biology that are associated with prostate cancer, but understanding which of those are important for determining whether or not a man has a good clinical course or a poorer clinical course. And so, this resulted, of course, in a number of different publications, which is great for all of our CVs, but at the same time resulted in 4 tests that are now in early stage clinical testing for actually stratifying patients with intermediate risk prostate cancer, localized prostate cancer, and potentially changing the way that those patients are managed based on the genomic or genetic profile that those men have in their tumor. We've launched as partners in a number of these programs, the CPCG and Canadian Prostate Cancer Genome Network. Amongst them, we've launched the International Pan Prostate Cancer Group, which is a consortium of I believe it's 9 or 10 groups now from all around the world to really tackle this problem in ways that individual countries can't, both in terms of just sheer number of specimens that we can work on, but also in terms of different population demographics. I had a quick look at some of the stats from our Canadian program just before I joined the call today, and I was looking at the proportion of patients in those studies that are Caucasian. and it's about 84%. You know, it's I was actually surprised it was that low, to be honest. You know, so we're missing an enormous amount of information about the differential biology of this disease. And we know that this exists in Asian populations and in Afro-Caribbean populations and in sub-Saharan African populations, which, you know, as you might expect, differ genetically from populations in North America and in the Caribbean. So, you know, we've invested globally to sort of try to leverage some of those resources that exist around the world. We've invested heavily and are continuing to invest heavily in research around PSMA, prostate-specific membrane antigen imaging. This is, for those who are not aware, this is a new imaging platform that can detect prostate cancer metastases with enormous sensitivity, much better sensitivity than has ever been seen before with things like bone scans. And so we've invested heavily in that, both here in Canada and around the world, to look at ways in which we can identify cancer that is recurrent following treatment earlier than we would have otherwise, and perhaps then allow us to intervene for those patients much earlier than would have been the case previously. And we've funded actually a large trial here in Canada out of the University of Montreal with Dr. Cynthia Menard, which is looking at using PSMA imaging to identify prostate cancer lesions that are present much earlier. And she's asking the question of, if you are able to identify those earlier than you would be with standard imaging, does that result in a change in the way that those patients are treated? Does it improve their outcomes? And, you know, what are the health economic and other factors associated with quality of life and those sorts of things around changing management in that way? You know, again, it's great if you can detect this cancer earlier, but does it ultimately matter in terms of producing a longer life for that man? And at the same time, does it affect their quality of life adversely? We funded a lot of work, again, around PSMA and using PSMA as a potential therapeutic, where we can actually detect the presence of this prostate-specific membrane antigen, which, if I didn't say, is a protein that sort of lives on the surface of prostate cancer cells, and actually targeting that with a chemical that allows us to very tightly focus a beam of radioactivity right on the prostate cancer cells itself. This is a strategy called PSMA theranostics, and it's actually been recently approved in the United States. It's still not approved here in Canada, but we're working hard to change that. So, you know, there are a number of examples like this, and we could go on and on talking about some of the great successes that I think we've been involved with and will continue to be involved with. But really, my purpose of being here today is to talk about where we're going. And, you know, as I said, Movember is an organization that is is changing and growing in a lot of ways, and consequently, some of the models that have worked in the past may not work now and need to be expanded upon, and we need to reevaluate kind of the ways in which we can have the best possible impact for the most men. And so with that in mind, I'd like to introduce you to the Global Real World Evidence Network, or what we call RWE. Like most places, we have our set of fun acronyms. RWE is our acronym of the day. And so a lot of these problems I've talked about in terms of what the issue is around prostate cancer, but fundamentally it comes down to this. Prostate cancer is a disease that takes a very long time from diagnosis out to either death from natural causes or other causes, or unfortunately in some cases, death from prostate cancer. That can be 20, 25 years in some cases. And therefore, it's very difficult actually to study this disease in its earliest stages, to ask what are the factors that result in a man being cured of his disease and never having to worry about prostate cancer again, versus one who has all the same conditions, but at some point has a relapse and goes on, unfortunately, to die from his prostate cancer. You know, what are the differences there, and how can we study them from day zero all the way out through the end of life? What are the socioeconomic and ethnic and access to care issues that prevent certain men from having good clinical outcomes or from having good quality of life after treatment? All of these things are important questions. And the problem is, because of that long duration of the disease, it's very difficult to study, and you need a lot of men to be involved, far more than you can ever have in an individual country. We're talking on the order of hundreds of thousands. And so we kind of took a step back a number of years ago and reevaluated this. How can we start to change this? How can we be involved in this space? And can we use the power that we have as a global organization to bring together as many people as possible? And in fact, the end result of that is our RWE. And so the idea here is to accrue expertise across disciplines and across populations, to facilitate effective collaboration around the world and within countries, to coordinate that collaboration and to make sure it runs effectively, and to engage with men and their families directly. And I emphasize a lot of men and their families, because this problem is so large, it really does require a global solution with enormous, enormous numbers of people that need to be involved. When we talk about things like ethnic differences in outcomes for prostate cancer, because of course, when we stepped back and took a look at what we were funding, and as I said, with the Canadian project as an exemplar, we found that the representation of non-Caucasians in our studies and in other people's studies was just, it was glaring, right? And so there's really a need to step back and understand not just the biology, because I think that's important, but also the other factors that are associated with that may play a role or be associated with the differences in outcomes for men of color. This is a couple of different articles that were published over the last few years that sort of took this paradigm of Black men have poorer outcomes with prostate cancer. They have more aggressive outcomes. And, I think there's this idea that, well, that must be biology. But in fact, it turns out that when you normalize out for some of the differences in income, in access to care, in some of those other socioeconomic factors, the biological impacts, the biological factors actually fall out. They don't actually seem to be making much difference at all. There's probably something biological there, and I think Neil talked about that probably earlier this morning, but there is an enormous impact of things that are non-biological. And in fact, these studies have shown that Black men present with more aggressive disease on average, but have similar, if not better, outcomes when you adjust for this. And so clearly there are factors that are non-biological that we wouldn't be capturing if we just sort of pressed ahead with the same type of model that we were doing before. And I like to use the analogy that when you're a hammer, everything looks like a nail, right? When you're a biologist, you look for biology. And in fact, we need to be able to capture things that are not biology and that have potentially as much or more impact on the way men are actually experiencing their journey through prostate cancer. And so consequently, for the Global Real World Evidence Network, we will be actively seeking to identify and rectify the disparate causes, not just biological, but socioeconomic, cultural, economic, all of those sorts of things that influence health income disparities. So the RWE is going to be really a network of networks, or a registry of registries that will accrue 500,000 men from 600 partner institutions in 19 countries over the next 5 to 10 years. With numbers of that scale, we have the ability to ask and answer questions that simply would not be possible when we're talking about cohorts that can be accrued within individual countries, which tend to be on the order of several hundred, maybe 1,000 if possible. So we can accrue these men, we can identify all of the factors that they experience or that influence their journey through the cancer landscape. So, what was their diagnosis like? What was their experience with biopsy? What was their primary treatment? How did they experience it? Did they have side effects? What were those side effects? How severe were they? Do they exercise? What's their diet like? All of those sorts of things. that we can capture through both biological data, but also what we call patient-reported outcome metrics, or PROMS data, where we can go in and learn from patients, what were their experiences. Aggregate all of that information and fast track accrual to clinical trials at a global scale. So if you're a person in South Africa, for example, or in Southeast Asia, you may not have access to some of the clinical trials that are ongoing in other places, but by being part of this type of a registry, we can pull that information and identify those individuals that perhaps need to be fast-tracked to some of those clinical trials. It allows us to centralize all of that data, and by data, again, I mean biological and patient-reported and sort of metadata, survivorship data, all into a central repository that clinicians and researchers from around the world can leverage. So if I have a study that I want to do and I say, I'd really like to have a population of men who have a certain characteristic, I can go into this database, this registry, I can pull out what I want, and I can ask that question on those men in particular. Because, while there might be 50 men of interest in Canada, there might be 1,000 around the world. And so the ability to ask and answer questions is very, very different, right? So, we really see the Real World Evidence Network as a way of bringing together different research topics, different researchers and clinicians, and again, as I said, men and their families into this larger umbrella where the whole is greater than the sum of the parts, because there's just questions that we can ask with a data set of this size that we would just never be able to in the past. I won't go into this too much, except to say that there are a number of avenues to this. It's not all about biological research. A lot of it is, but it's also about things like survivorship groups like the Walnut Foundation being directly engaged with to learn from men. There's data that we can capture from men like you and your families, that we haven't been capturing uniformly, and that we haven't been learning from, consequently. And so the Real World Evidence Network really aims to change that and to bring people in much closer to the process, engage with them in the research process, engage with them in the whole machinery of learning from the disease and the things that surround it. We have two initial programs that I can announce that have been launched publicly, but I can tell you about today. There are many more in the works, but really two initial programs since we launched the RWE late last year. The first is a program, a global program to prevent disease progression in men with high-risk prostate cancer. And so, as I said, in this sort of highest stage of the quote-unquote localized prostate cancer, our goal here is to identify men who could potentially, in whom we could potentially prevent progression to local or distant metastatic disease, or if we can't do that, at least delay that and improve the duration and quality of their life. We're also talking, though, in this program about men with locally advanced disease. So this is disease that perhaps has spread to a local lymph node, although I'm not sure that's technically called locally advanced, but a local lymph node, or has breached through the prostate capsule, as well as men with oligometastatic disease. So as I said, this is the disease state where there's perhaps 3 or 4 spots of cancer outside of the gland that could potentially be given radiation therapy, very specific targeted radiation therapy, and potentially be cured. This is really the last bastion of potential cure. And so all of these disease states really fit in under the umbrella of this program. And the idea here is to leverage the international community to develop strategies that are both biological and non-biological to understand how do we prevent men from progressing to advanced disease. Philosophically, I think as a group, we feel that the best way to prevent men from dying of metastatic prostate cancer isn't necessarily to learn how to treat metastatic prostate cancer better. It's to prevent men from getting metastatic prostate cancer in the first place. And so the process there is really to identify those strategies up front so that we can focus in on this disease group and make sure that these men are having much better outcomes than they currently are. We have a global steering committee that's been engaged in this process. There are 33 investigators now around the globe. A steering committee is a set of 5 global experts from all disciplines of prostate cancer research, from urology, radiation oncology, basic science, radiology, epidemiology, psychosocial health, and so forth. And so we have a team now that we've assembled, and ultimately the goal here is to, as I said, to develop what we've called a biomarker-informed treatment strategy, but it's really about using as much data as we can to inform our treatment strategy to ensure the right treatment for the right patient at the right time for men with advanced disease. So as I said, we had 45 expressions of interest, from which we have now 33 investigators involved in this. We're finalizing the sort of final proposal right now, and we should see a launch of this as an active research project within the next 6 months or so. And this will be a 5 to 7 year program, really aimed at, as I said, identifying ways in which we can improve outcomes for these men and reduce the number of men that are progressing. And our goal, it's an ambitious one, but our goal is a 30% reduction in the number of men with advanced prostate cancer. And the first way we achieve that is by making sure that men with the highest grade, highest stage cancer that's localized to the prostate are not progressing to the more advanced stage. The second program I can tell you about quickly is really the other side of the localized story, and that's a program looking to develop a dynamic risk-adapted approach to active surveillance. So these are men who traditionally have low-risk disease, and we know that very, very few men with low-risk disease are going to go on to die from prostate cancer. It's substantially less than 1% of those men. But the fact remains that those men are still experiencing bad outcomes, and we need to identify why that is. Why are these men dying of their prostate cancer? And if we can identify them up front and perhaps say that they're not candidates for active surveillance. Conversely, can we identify men accurately who have more indolent disease and can be safely triaged into active surveillance programs? And we've already seen this here in Canada. I think we're in a good position around active surveillance, and it's not necessarily the same around the world because of the historical prevalence of active surveillance programs here in Canada. It was really developed first by Laurie Klotz at Sunnybrook here in Toronto. But can we identify subsets of men with intermediate risk disease who have good clinical features or good pathological features that could in fact be offered active surveillance? And we're already seeing this. There already are men with favorable intermediate risk disease that are safely being offered active surveillance. So, the goal here is really to maximize the size of that red circle. It's to understand what is the maximum number of men that can safely be placed onto active surveillance programs. And the fact is, we just simply don't know how to do that right now. There's a striking statistic. When you look at men with low risk prostate cancer, Black men with low risk prostate cancer have a 2-fold increased risk of dying of prostate cancer. Again, the absolute numbers are low, still below 1%, but actually have a 2-fold increased risk of death versus non-Black men of dying from low risk prostate cancer. And the question is, why is that the case? Is it biological? Perhaps. Are there other factors at play there? Also perhaps. And so understanding all of those factors that go into this are really the sort of the keys to this new program. The focus of this program, again, will be around personalization of active surveillance across the board, right? So how do we get more men to consider active surveillance? How do we get more physicians in non-academic centers where they might not be up to date on the recent literature? How do we educate them and help them help their patients to understand whether or not they should consider active surveillance and talk about the risks and benefits of considering that? Is there a tool that we can develop for use in the clinic that takes into consideration all of the factors that influence a man's decision and develop a unified strategy, a unified tool that we can implement in this setting? So the call for this went out just recently, about 2 months ago. we are just now in the sort of assembling a global steering committee phase. We have, I believe it was 80 applications for people from around the world, from research groups that are looking to participate in this type of an endeavor. So you can see there's already great uptake from the research community. So 80 groups that span the breadth of interests, again, from basic science all the way to what sometimes are called the soft sciences, although I don't love that term, but things like psychosocial supports and epidemiology and those sorts of things. And so the goal here is, as I said, to maximize the number of men who are choosing active surveillance as their first option. And so we've set ourselves the goal of a threefold increase. And this is safely, right? So it's not just about telling men that they should go on active surveillance. It's telling men that they should go on active surveillance because their outcome is extraordinarily likely to be good on active surveillance. So to summarize, Movember has put in a lot of money, invested a lot of money, over $107 million since 2008. And we're proud of that investment. And I think we've seen enormous strides across the breadth of prostate cancer research, from localized disease all the way to advanced metastatic disease and everywhere in between. But we think that the time is right now to start to think about implementing a lot of those research findings that we've made. Our decision or our approach will be to fund less of the basic science type of thing and much more of the how do we turn those discoveries that we've made since 2008 into new therapies, new drugs, new treatment types, better ways of triaging patients and so forth. So we think we can do that through unprecedented global collaboration. We create this registry of, as I said, 500,000 men that can be drawn on by anyone who wants to ask these type of pertinent questions, to explicitly, not just happenstance, but explicitly address inclusion of men who have been underrepresented in biomedical research and support programs. And so I can't stress enough how much this is an ongoing core part of the RWE, is to make sure that the findings that come out of these studies are representative to the extent possible of the global population, which is not 84% Caucasian men in our Canadian study. It's very different than that, obviously. And so we need to make sure that we address that, and that everybody who applies for funding through the RWE is going to need to have a statement of how inclusion and equity is part and parcel of the project that they are proposing. Ultimately, as I've said, we want to reduce the number of men who are being diagnosed with or progressing to life-threatening disease. And there's a number of ways that we can go about that. Advocacy is going to be a part of RWE. And I haven't spoken about that, but this is going to be a space you'll see Movember start to move into, particularly here in Canada, where we've seen Prostate Cancer Canada amalgamate with the CCS and really leave that space kind of wide open. And so you'll see Movember more and more start to move into the space of advocacy. That doesn't necessarily just mean lobbying government. It means advocacy in terms of education. It means advocating to primary care physicians, to specialist physicians, to men directly, and potentially to government as well. So I just want to say thank you again to Ken and to everybody for coming today and listening and inviting me here to talk today. It's an exciting time at Movember. As I said, a lot of things are changing, but a lot of things are changing, we hope, for the good and the more inclusive and the more impactful. And watch this space. So thanks again.
Yeah, thank you, Mike. Very informative, and I think it's refreshing to see the work that Movember is doing in this space. We've got a number of questions. I'm going to ask Nana if she can read the questions for you.
Okay, Dr. Farida. The first question is, how is Movember regarding research on low-risk prostate cancer and active surveillance? Is Movember involved in advocacy in addition to research?
So I suspect this was read before the end, right? So yes, absolutely. So it's a space that we have not been in traditionally because it was the way that the organization was set up. It was very much we funded programs through Prostate Cancer Canada, and they would go out and be the advocacy group, and that worked very well. Now with Prostate Cancer Canada no longer existing, there's a space open for that, and we have heard loud and clear. And unfortunately, Atika Mohammed was supposed to be on the call today. She couldn't make it, but she and I have worked over the last year and a half, really, to talk to groups like the Walnut Foundation and others to understand, you know, and heard loud and clear the importance of Movember getting into that space. And so we're very much committed to that. We have just actually hired a global director of advocacy, and so you will start to see that funnel down into programs. So not just in low risk disease, but right across the spectrum.
Yeah. Okay, great. Thank you. Second question. Could you say what criteria is used to select countries for the global RWE network, and also how many African countries are included in this network?
Right. So largely, I mean, there's two ways of thinking about this, right? So the first is to think about where the researchers are located, and the second is to think about where the patients and men associated with the projects are located. So I'll give you a perfect example. So we partner with Dr. Vanessa Hayes, who's in Sydney, Australia, but she is the, I think, unquestioned world leader in looking at the genomics and the biology of prostate cancer in sub-Saharan African men, and has shown enormous, really just groundbreaking work around the differences in those diseases, not just compared to Caucasian men and Asian men, but compared to Afro-Caribbean men in North America. Completely different disease. And so she's not based in Africa, but she works very closely with local collaborators. So Movember will, I mean, the calls are open. It's ultimately up to the research communities to put together applications for this type of funding. We distribute as broadly as we possibly can. We have formal collaborations in South Africa, but we have access to whatever sort of the researchers have. So it's difficult for us to be in each country, but it's easier for individual researchers to forge those collaborations, is to say, you know, this is an aspect of that is being under addressed, and we need to assemble patients and researchers and clinicians in those countries to actually bring things forward.
Okay, great. Thank you. And third question, when do you see the PSMA imaging being widely used in the Toronto area?
Yeah, it's a tough one. So, you know, a lot of you will know of the registry that's open through Princess Margaret and a couple of other institutions across Ontario, and really is the only way to get access to PSMA at the moment. So we are working on that problem. It's not I can't really give you a date specifically in terms of when this is going to be available. I would hope that it would be as soon as possible. You know, I think one of the challenges in Canada is that, you know, to get something like PSMA imaging approved, there has to be really strong evidence that it changes practice and that it results in differential outcomes, right? And so there has to be that evidence collected. As I said, we're funding a very large trial in that space out of the University of Montreal. And so hopefully that will go a long way to changing that narrative and to getting people to think about approving this. But, you know, unfortunately, I can't put a date on it at the moment.
Okay. And last question, sorry, last one question. Given the high incidence of prostate cancer in the Caribbean area, will you be including those countries in your logo?
Yeah, so again, the same answer is that, you know, it ultimately, absolutely, but it ultimately depends on researchers. But, you know, I will say, just to preface, or just to put an end to that question, or to put bookends on that question, that's the word I'm looking for, is to sort of say, this issue of inclusion and equity and including underrepresented communities is part of this, right? And so it's not just, it would be great to see, and, you know, the panels that are reviewing these programs kind of can say, like, well, you know, it's like one of the tick boxes on the application. It's actually required. So you've got to have this. And so we've issued the challenge to researchers and clinicians to say, go out and forge those collaborations. Go out and identify your colleagues who are working in the Caribbean or in Africa or wherever it is. Identify those cohorts and work with them and come back with global networks that that don't exist today, potentially, right?
Yeah. Okay.
Okay.
And last, there's one more.
Go ahead.
Are there any alternative medication in the health store for prostate cancer?
Unfortunately, I can't comment on anything related to that.
Yeah.
Okay. Thank you very much, Mike. Really appreciate it. It's been great presentation and really great to hear the things that Movember is doing. A lot of people do ask us, with all the money that Movember is raising, what are they doing with it?
Yes.
So at this point, I'm going to bring Anthony Henry in and also Winston Class to run the next part of our presentation, which is the panel discussion. And I'm going to bring all of the presenters in. So Dr. Neil Fleshner is on the phone. So, so everyone is back in. So
I'm here, Ken. All good.
Great. All right. So Anthony, if you want to proceed.
Okay. Thanks, Ken, and thanks, panelists, for rejoining this group. So the objective of two organizations, the African Cancer Support Group and the Walnut Foundation over the years, have been primarily around self-help and how we can make a difference in the people that we are interacting with, as well as engaging communities and stakeholders like some of these folks assembled here today. So this next phase, we're going to look at, some of the issues around the best way forward, best practices, and things like that. But before I do that, I want to call in Winston Class to say a few words about his personal experiences. Winston is a board member at the Walnut Foundation, but he also has decades of experience participating and running support groups. He actually chairs a support group geared to men with advanced prostate cancer. So Winston, could you just say a few words to open this segment? And then probably what we'll do is if folks have questions, they can put it in the chat. And then I'll also have some questions here for the panel to mull over. Winston, go ahead.
Okay, thanks, Anthony. Really, I'm almost a surrogate for the attendees out there, because I know with the webinars, you're not able to interact directly with a specialist. So I know you'll be watching at me, and I hope I represent you well. As I listened to the presentations, a number of things that they said triggered various incidents in my personal journey. I certainly can't state all of them. There's limits to the time, but I'll do some top of mind impressions, which I'm sure are going through the minds of just about all the attendees there as they listen to presentations. And perhaps that can help you to, in terms of framing your questions. And what I kept asking myself, whether it was an emotional thing or an interaction with the health system, was it just me? And it just happened to me by fluke? Was it a Black thing? Does this happen to Black men? Does it happen to all men? Am I overreacting? And that is the question mark I had over each one of them. So I'll start first with the mental part of it, more of a cultural thing. Some things that came out of Dr. Kwatu's presentation. When I was diagnosed, I went through a depression, not a serious one, for about a week. I was just in a fog. And then the moment I was persuaded to just get out there, collect your data, and fight the damn thing, the fog just miraculously lifted. Now, is it me? Is it a Black thing? Does it happen to everybody? I throw that out, okay? Soon after I was diagnosed, I tried to start a Black support group, and I tried it in the most modest way possible. I got the wife of someone who was diagnosed to cook some good soup on a Sunday afternoon, and I had about 6 to 8 men, Black men around me. And I thought, well, okay, that's a good start. The odors from the kitchen, the aromas from the kitchen were smelling good and all of that. Football was on. Everybody kept talking about football. For an hour and a half, they knew very well why they came there. So I turned to the host and he turned to me. And I think I got what he said. And I immediately went to my story. I just cut the football and I just talked about myself. And the moment I said it, the guy next to me, who happened to be a garage mechanic, he just started talking and he couldn't stop. Okay? Is this situation a general situation? Is it a Black situation? Is it a man thing? I'll leave that there with the mental. Genetics. The top of mind one for me is that my son. I am trying to get him to do regular screening. And he's kind of very casual about it. Now it upsets me because I know he should. Is it just happening to me? Again, the same questions. It's very important when you have younger members of the family and you know about the genetics or the connection with this prostate cancer, that you motivate them to go through prevention routines or whatever. And so it's something I threw out. I mean, I'm sure it's a struggle that people with a history of prostate cancer go through. Then I'm just going to mention 2 points on masculinity. One is, it was a very interesting one, and it reflects my background from the Caribbean. When I was diagnosed with prostate cancer and opted for surgery, the specialist turned to me and said, well, look, I'll tell you something, you know, your prostate gland is a little bit large for the surgery, and we're going to give you something to shrink it. But at the same time, it's going to reduce your sex drive. And I said to myself, oh no, I can't think of anything that could reduce my sex drive. Well, I took the pills and it was a moment, it was a eureka moment. It was a very sobering moment. It did reduce my sex drive completely. It's the macho kind of thing that goes with sexuality, and I had to revise my old thoughts about it after that. The second thing that happened is that, and again, back to the sexuality and the masculinity, is that I think it's so close, it is very hard to share it. It was very hard to share the emotions that I went through because it was so close to me, okay? And finally, on the exercise part of it, I come from an older generation of men, and I hear the benefits of structured exercise and doing it in company, but I just can't get myself to do it because it was not part of my culture. So I do my walks, I do my cycling by myself. I have stuff to do with rowing machines and stationary bikes in the winter. I know I should go out there and do a structured thing, do a group thing, and it's more motivating, but I don't do it. So here's some top of mind impressions, and I'm sure similar impressions are going through for the people in the audience that might lead to questions or different questions, and I thought I'll just kick this off. Back to you, Anthony.
Okay, thanks, Winston. Thanks for opening up yourself and letting us into your thoughts on this. Probably I want to turn it over to the panel, and maybe somebody wanted to comment on a specific piece of what Winston touched on. And also for those in the audience, feel free to put something in the chat.
But I guess I should say something. Thank you, Winston. Thank you, audience, for sticking with us for this long. It's been a couple of hours. I think, Winston, your situation is perfectly average in terms of representing the experience of Black men who discover they have prostate issues and how they deal with it. That's been the experience of my very best friend, the experience of my dad, who actually had prostate issues during COVID, just at the beginning of COVID. So he had to live with this, you know, the thing they stick in your penis. I forget what it's called again. Because the prostate was you would never retract. In any case, I think the complexity of masculinity, hypermasculinity, which is something that's prevalent amongst our young men because of the societal limitations on expression of manliness, by which I mean what it means to fulfill one's social responsibilities as a man, and the limitations that systemic racism places in the way of Black men from fulfilling those things. But just we deal with a lot of stigma, and public stigma around prostate cancer, mental health illness, all the diseases, coupled with self-stigmatization. So the public stigma is something many people report is as bad as the disease or the illness itself, because the stigma brings a sense of shame and a sense of questioning one's identity as a man, as you discussed. But then there's a self-stigmatization which actually sustains the delay in help seeking. You only had a week, so if a week was the bar, we would be pretty good. But unfortunately, for many people, that period of time, a stage of denial sets in, and it could extend for months and even years, that people conceal their illness because it's concealable. And you touched on it, sexual functioning, which is actually part of the social definition of Black maleness. When you lose that, it's not just you have to deal with it within your own community. It actually has ramifications for what you have grown to understand as being, a definitive trait or a definitive attribute. So really, to some extent, you lose a check mark on the identity checklist.
Right.
And you wonder, well, what comes next when I can't fulfill this basic function? At the very least, this is what I was good for, but here I am, I can't even do this. Right. So I think really, one of the things I didn't touch on a lot was the ability to reduce stigma. That, there's a huge compilation of evidence in the mental health field that stigma expresses itself across all society, but most problematically, our health professionals have the same level of stigma as society. And in mental health, that means psychiatrists, nurses, social workers, and psychologists have similar levels of stigma as everybody. And we assume otherwise. You assume a psychiatrist would be less stigmatizing than an ordinary member of society, and that's not the case. But what we did learn is, with stigma reduction interventions, including education, interaction with people who are mentally ill, when they're well as when they're ill, and accountability around expressions of stigma, you can reduce stigma in healthcare settings, and you can make the place safe for people who are mentally ill, and they feel more welcome, they're more likely to express themselves. I don't know what the situation is like with prostate, but since I was personally involved with some mental health research, and it was demonstrated, I believe that there's a huge potential with prostate stigma research within our community as well as within healthcare settings.
I was wondering if John perhaps might have a comment on the mental health piece, stemming from what Winston had to say.
Yeah, thanks. Yes, so just the context. I sort of chime in on the self stigma, and it's one of those ones that's super interesting. So we're often really hard on ourselves, and when we're hard on ourselves, it's hard to find remedy because it's all about deficit. And I think the self-stigma is just one of those ones that will often look internally, you know, especially around, if we've got some sexual dysfunction, for want of a better term. So again, just trying to think about it differently and trying to create the space for conversation. But definitely when it's held inside and not discussed and not kind of worked out, it's very, very challenging, right? So that's we in guys who experience mental health challenges too, oftentimes we'll find higher levels of self-stigma in those guys than guys who are not afflicted with some of those challenges. Super interesting.
Thank you. And it's so important to be aware of the resources that are available. And some of them were shared earlier today in terms of, supports for mental health and also supports in terms of exercise, for example. Moving along, one of the issues that I want to talk about is who needs to be educated and how. We often come across in our travels at the Walnut Foundation, Black men in their 50s during our outreach efforts who have never had a PSA or digital exam, some of whom are a family doctor. Can the panel speak to how we might best deal with this issue more effectively going forward?
Ken, maybe I can, and group, maybe I could take a stab at that one.
Yeah.
Look, I think it's a bit of, as I'm sure many of you know, there remains controversy about PSA screening for prostate cancer. And I think sometimes that gives family doctors an easy out not to discuss the pros and cons with the patient. And I don't think we should be letting family doctors get off the hook like that. So I think, and this is why we want to educate the medical community, because certainly those at higher risk, logically speaking, would deserve a better conversation about risk, about screening, as well as the pros and cons. Secondly, so we want to raise the level of education around primary care, and I also think, in today's world with social media, we can even overcome some of those problems by generating a movement. I mean, it sounds daunting to generate a movement, but there's so much goodwill right now and so much ease of touching millions of people not expensively with social media that I don't think we should be intimidated in a negative way from trying to do something like that. We cannot, it breaks my heart when I see men come in with metastatic disease and they're old, some of them are older, some of them aren't. And so I think we really have an opportunity here.
Okay, thank you. The next question has to do with second opinions. We have been told by some men that they never considered getting a second opinion on their diagnosis or proposed treatment plan. Others have experienced severely strong pushback when they ask to be referred for a second opinion. Can the panel comment on this and how the patient might deal with this issue? Again, we are trying to focus on, help. How do we help? How can we help?
Well, I think, again, I'll take a stab at first and then we'll hear from others. I apologize because I'm on phone. I can't raise my hand. Look, I think a lot of patients I see are second and third opinions, but I do see patients as first opinions. I would say at least 80% of the patients I see, I offer them a second opinion myself, mostly because radiation is, in many cases is a reasonable alternative to surgery, and thus the patient should be informed about both. And I feel the radiation side of things is best done by them as opposed to myself as a surgeon. There is about 20% of men, 30% who say I'm not interested, and that's fine. So again, this gets to educating clinicians, but also, I never understands me what kind of pushback one gets from a doctor who's offended by a second opinion, and you this is not the National Health Service. You have the right to go see somebody else free of charge in the Canadian healthcare system. So we need to empower the patients as well.
Any other comments on this from anybody else?
Just from a mental health point of view, I think I've seen the groups do really nice work in terms of helping guys slow it down to make an informed decision. And oftentimes you're feeling very rushed, got to make a decision, got to jump in there. And I think, the groups do a nice job of just trying to help slow it down to a point where, that due diligence to check out the options and make an informed decision, because it's healthier in terms of reducing that regret, that potential regret, that decisional regret that can come with having, taken a particular pathway or not having done all of the work of it. So I think, again, the group does a nice job generally of being able to just put it in perspective, because it's probably been there a while, the cancer, and, it's something that can take a little bit of time to get a second opinion.
Are there any questions in the chat at this point?
Yeah.
Or should I continue?
So there's some questions in here. This one is for Dr. Kenty, but I think it should be anyone can answer. Any idea why there's such a high incidence of prostate cancer in the Caribbean? But anyone can answer that.
I would suspect it has to do with genetic risk combined with probably a high incidence of metabolic syndrome, which was touched on by our first speaker, hypertension, diabetes, dietary factors. And then to add the third sort of, fuel to the fire, maybe cultural issues, as we've discussed, around getting tested early, masculinity. So to me, it's probably a perfect storm for that unfortunate statistic.
Yeah. Dr. Kenty, any comments? You're on mute. Sorry.
You're muted.
You're muted.
Yeah, so I want to answer that question, but I also want to very quickly sort of reinforce the point about primary care and about so personal empowerment and primary care, holding primary care accountable. I actually asked my primary care doctor is retired, so I have a sort of a stand-in until I get a new primary care doctor. And about less than a month ago, I'm doing my regular checkup, and I said I would like to do a PSA test, get a test. And she told me no. She told me I should think about it, and she gave me some forms and said, really, that she doesn't think it's worth it. I'm not showing any risk. I'm not presenting with any symptoms that suggest I need it. And she actually, I didn't argue. I didn't argue because she's not my permanent doctor. So I said, okay, I just do, it's a teachable moment, but for me anyway. So actually, this is the second opinion. Why would I I know that I want to do this. So, I go ahead and I get somebody else who will help me do it, because that's not a satisfactory response. And she didn't factor my cultural identity into her feedback to me. So that was number one. Anyway, the Caribbean is an incubator for communicable diseases, precisely because it's rooted. The society has never moved away from its slavery past, and it has never dealt with the consequences from diet, behaviors, the structure, the inbuilt structure that people assume that because the majority of the population is Black, that the culture is reinforcing and positively Black, which it isn't. We have still many legacies left over, particularly in diet and nutrition, that should be questioned and should be challenged and should be changed. And we have the University of the West Indies, but there's much more that needs to be done in this regard. But I think it's due to the slavery legacies that persist and remain. Slavery and colonization. And remember, we only ended the colonial period in 1960. which is 60 years. So, you know, we still have legacies to deal with.
There is another question here. Our masculinity is largely influenced by our father, background, and community. When we're infused into another culture, what is the best method to influence change of the learned behavior? You want it, John?
What an amazing question. So it is interesting. So that oftentimes, and I can just say that some of the guys that we've spoken to that might come from a distinct ancestry and aligned to many of the masculine norms within that culture are conflicted a little bit. And I think that vignette that I offered of George, you know, sort of goes some way towards, you know, saying some of those tensions. Masculinities are really interesting because their performativities generally, in whatever context you're in, you might show up a little bit differently to satiate the crowd or to fit in, so to speak. And I think that's what happens a lot of times when we're from other cultures and we're in a dominant culture and we want to fit, but we also don't want to relinquish, you know, some aspects of our past or our ancestry that we value. I don't know if I'm fully answering this question, but just to say, I think about it a lot in terms of plurality, and we talk to guys about their masculine values as well as their virtues. So we try to be strength-based, because the last thing I want to do is say, you know, that somehow masculinity is bad for you. It is not. It can be strength-based and asset building, and the deficit piece around toxic masculinity is deeply unhelpful for many men who reside in respectful places and do their best to show up and be the best they can be. So I try to think about, you know, that reconciliation about how to fit, but also honouring your past, your ancestry, the things that matter to you, and recognising there's always going to be shifts within it. So I probably pleaded the fifth there and didn't really answer the question, but I hope it offers some kind of sense of, you know, that it is a plurality. It's not a single thing.
Yeah.
Okay.
I have a response.
Yeah, sure. Go ahead.
There is
I could only quote from my personal experience. Within the culture, particularly with prostate cancer and its association with sexuality, there's so much disinformation and misinformation and rumors and myths that you find that when you're diagnosed, you almost react to the disease, not to your benefit. And my exposure to the mainstream support groups helped me quite a bit, because they taught me that you rise above it, look at it as an issue, as a problem, and just attack the problem, and then you're more proactive. So in that way, it created a cultural sort of change in the way I am. I looked at the disease, and it was good for me.
So that goes along with Winston with a comment from someone joined from the UK, and it's a very long comment, but it said, the person said, I think it's also the stigmatic, my tongue is getting in front of me. The stigmas of being cancer, of having cancer among the community, and the taboos associated with cancer.
Yes.
So there's a lot of stigmatization within the, you know, Black communities about cancer. I think we're finding that all over.
Yeah, can I just add a point to that?
Yeah.
Because stigma doesn't express itself until you have the disease. You're not dealing with stigma, understanding stigma, or repudiating stigma. You only find out about the stigma when you actually have the condition and you're dealing with it. So in terms of educating yourself or educating your family prior to that, that doesn't really happen, because you don't even know you had the stigma. Right. It's only when the condition expresses itself and all of a sudden, you know, your wife might want to go to bed with you, or your husband might, you know. The other thing is around gay men who have prostate cancer, Black gay men who have prostate cancer, whose sexuality is an issue and whose masculinity is an even deeper issue. There's all of these things are compounded. And but the point to note is that the stigma doesn't express itself until you have the condition. So you can't really prepare yourself to be able to deal with it. You don't even know you have the stigma. You don't even know your family have the stigma, your friends have the stigma. And thus the challenge is really a complex one.
Mhm.
So we next want to move on to new therapies. And the question is, and how the audience can access these. So can the panel comment on access to new therapies and how one might access things like new drugs and new procedures, like transperineal biopsies, for example, which are not available in some centers, like say Peel region, for example, where I am right now, transperineal biopsy is not offered. Any of the clinicians can answer that piece?
Yeah, I mean, I could take a stab. Transperineal biopsy of itself is still a bit of a controversial topic in terms of whether it truly represents a step forward or not, especially in the context of the Canadian healthcare system. But access to new treatments and procedures in general, the way it sort of unfolds, particularly in Canada, is interesting because usually the Americans get it first. And that's particularly true around medication. You know, Canada has got a very strange system because Health Canada approves, then provinces are responsible to pay. So it takes them a good 12 to 24 months to decide whether they want to pay or not. And in that period, you often have, in particular, a spotty access to those new treatments because sometimes the pharmaceutical companies will create programs of free access to the drugs, but they're only available in certain centers of excellence, et cetera. So there's always going to be a disparate sort of patchwork of accessibility in the Canadian system. And by the way, each province has its own set of rules and processes. So sometimes you can have a drug available in Ontario, not available in British Columbia, for example, or Alberta. Radium was never available, a drug called Zofio in Alberta, yet it was in Ontario. Robotic surgery was never reimbursed in Ontario, literally till about 3 weeks ago, whereas it's been fully reimbursed in Alberta for the last 8 years. So, you know, I think the best way for patients, again, to do this is to navigate their healthcare systems. You know, I work in a major center. It's easy for me to say, but, you know, shop around a little bit, read, and see what's available. And again, PSMA imaging is another example Dr. Fraser talked about.
Okay, thank you.
There are two questions in the chat I want to get over with. How often should one have regular screening done if not in a family history, if there's no evidence in family history? Dr. Fleischner?
Yeah, again, it depends on risk. What I tend to tell patients is an average risk patient would be age 50. You know, annual PSA is very pragmatic. I mean, there's some evidence if your PSA is less than 1 at age 50, you probably don't even need another test for 5 years. The problem with that, which I think is great, the problem with it is people tend to forget to do the test, and then they wake up and they're 63 and they said, oh my God, I haven't had a test, and they get diagnosed late. So I think pragmatically speaking, age, you know, once a year, age 50 for an average risk male, high risk male, more often, probably every, you know, starting at age 40. For the genetic risk males we talked about, we're now doing annual MRIs, for example, as a hyper surveillance or a hyper detection strategy. The only other piece I would add is I still see PSAs being done routinely in 75 and 80-year-olds. It probably should be stopped at a certain age, 72, 3, 4. Why? Because the cancer is largely detected that way, killed 15, 20, 30 years later. There's no point in creating cancer statistics and all the downsides that does in elderly people who are unlikely to who are likely to have the cancer, but unlikely to die from it.
Okay. There is another one. Is there a special procedure or therapy for cancer at the rear of the prostate? Dr. Fleschner?
At the what of the prostate?
At the rear of the prostate.
Rear of the prostate.
Rear.
The whole prostate's in the rear.
Probably closer to
R-E-A-R?
the
Sorry.
Yeah, REAR. Probably closer to the.
Well, the whole prostate is just in front of the rectum, right? It's in the lower pelvic area. They all are. I'm not sure what the specific question. There are sometimes cancers. There are unique cancers sometimes in the opposite of the rear, in the what we call the anterior, or if you imagine a man lying flat on a table, the tumor would be, most tumors are in the prostate closer to the floor. About 10% originate in the zone of the prostate close to the ceiling. If that's what the question refers to, most cancers arise in the posterior or the floor side of the prostate if a man's lying flat. And there is a few additional treatments. So the main one being high intensity focused ultrasound, HIFU, but it's not reimbursed in Canada, and still learning a lot about it.
Okay. All right, that's it, Anthony.
Okay. So we're bringing this to a close then?
Yeah.
Okay. All right. Okay. Thanks everyone for participating in this segment of the conference. We hope you learned a lot today, and a big part of what we're trying to do is to make a difference, improve outcomes, and so I hope we met that hurdle in terms of what we presented here today. Again, the hope is we have better outcomes, improved outcomes for all the folks in our environment. Thank you.
And so, Anthony, before we wrap it up, I just want to just share for everyone our support group. So we have a support group, a virtual prostate cancer support group, a safe space of Black men that we talked about. The next meeting is on October 27th at 7 p.m. Eastern time. This flyer is going to be on our website. So www.thewalnutfoundation.com. If you're recently diagnosed, you're in treatment right now, or you're post-treatment, and would like to be in a safe space with other Black men discussing, it's really a fantastic place to be. All of the men who show up leave with something. So I'd encourage you to join the group and share your experience or learn from the people within this. Okay, so we're now 15 minutes past our 2 o'clock deadline, but it's been a great conference. It's been very informative, and I know that everyone left with something. I really want to thank the presenters. Everyone had something specific and different to say, starting with Dr. Kenty this morning, right on up until Dr. Fraser. It was all great. It's going to be recorded. It's being recorded, and once I get permission from the speakers, we're just going to place it on our website so people can go back and review it again. So thank you very, very much to everyone. It's been a fantastic conference. Thank you.
Thank you. Take care.
Bye.
Thank you.
Thank you, Dr. Nick Fleschner.
Thank you for involving me.
Thank you.